in Nigeria, Borno State. And this is a huge opportunity for us to learn from the implementation here in Tanzania. And yeah, we are here to learn. So yeah, we are grateful. Thank you so much for having us.
Asante sana, Dr. Ukaili from Nigeria, Director of Family Health.
Thank you very much. I would say the organizers of the SBBC, the SBBC Annual Stakeholders Meeting, the Ladell Global Health, the directors and representatives of the Ministries of Health here present, all country representatives, SAFER, Haydon Uderan Hospital, hosting us here, donors, development partners, and implementing partners, the academia, distinguished ladies and gentlemen. Karibu. I bring you greetings from Nigeria, particularly from the coordinating Minister of Health and Social Welfare, Professor Muhammadu Ali Pate, who is very passionate about crashing maternal mortality and newborn mortality in Nigeria. In Nigeria, we have the challenge, just like most other African countries, we are still far away from achieving SDG 2030, particularly on SDG 3.1 and 2, on maternal mortality reduction, as well as skilled birth attendance. Also, our reproductive health indices, particularly maternal health, newborn health, maternal and newborn mortality rates, are unacceptably high. And we are very privileged and happy to have a president and coordinating minister who have a very strong political will to do the best and see how we can crash MMR and neonatal mortality rate in Nigeria. So, back home, the Ministry of Health, through his leadership, a very pragmatic one, have packaged special interventions. We have the MAMI project, which is a special project that we packaged to reduce maternal mortality reductions in 172 AGs with the highest burden of these indices. We also have our NEMSA transport system to reduce the delay 3, and we have several other interventions, increasing access to quality care, and quality of care is also a priority, and that's why we are very happy that Nigeria was invited and is part of this very engagement, because the SBBC brings a lot of improvement, quality improvement and to care, which we all know will reduce maternal and neonatal mortality by 50%. And so it's a great opportunity for us to be learning from this very experience. And since we came, and even from our previous engagement through the organizers right from Stavanger to this place, the SBCC is a great intervention, innovation, initiative that Nigeria presently, I would say we're already converted as far as this intervention is concerned. And we are here to learn. There are many of us from Nigeria team. We've come here with a very positive mind, and we are learning and we are learning and we are taking it and we are taking it. And even my colleague, the director in charge of NEMSAS, is also here. And so I want to use this opportunity to say once again, thank you for granting us this opportunity, and we will be going back home to plan better and begin to implement SBCC in Nigeria. Asante.
Excellent. Thank you so much. So now we have a visit from UNICEF, Dr. Mary Azai. And I recognize that Dr. Mokwane has just arrived, so can you stand?
Thank you so much. Good morning, colleagues. Good morning, everyone who have come to this meeting. Yes, my name is Dr. Mary Asayo Mweteni from UNICEF Tanzania Country Office. I first of all want to appreciate and thank you, SBBC team, for inviting UNICEF in this meeting. I want to appreciate the teamwork from HIDOM, SBBC team, together with the leadership of the Ministry of Health, Ministry of Pure Raj, for taking up this intervention. And also, I'm glad to hear that SBBC is also being implemented in other countries. As UNICEF, we have a shared vision of reducing newborn and maternal mortality. And SBBC have really shown the way. We have seen a reduction in maternal mortality, and we hope that other countries will also benefit from this intervention. So UNICEF, we are supporting this program, and we also feel that SBBC has really addressed the key challenges which we face, especially during labor and delivery. And through this intervention, through this program, we have seen that even the healthcare workers, even the families, the immediate families, and the nation as a whole is benefiting from this intervention. So we are here to learn, especially for the achievements, and we look forward for the discussions and the lessons from this program. And I wish everyone a good meeting. Thank you.
Asante sana, Dr. Mary. Now from this group of collaborators, our last partner will be GFF. Alison, please.
Good morning, everybody. It's a great pleasure to represent the Global Financing Facility at this amazing, wonderful day today, especially this year with the publication of the results, and to be able to really celebrate the success that all of the teams implementing SBBC have been able to achieve. They are phenomenal. GFF has been involved since, the vision about 6 years ago was to think about what might really be an innovation that we can take to scale. There was a call for proposals. We had over 300 applications for this particular grant opportunity that was very well kindly supported by the Norwegian government and the Adel Foundation. And within that, this SBBC program was one of the highest ranked proposals, or the highest ranked proposal. But at that time, you don't expect these sort of results. So we are thrilled to be here to hear all of the lessons learned today. I'm not on my own here, and I want to pay respect to the fact that we have amongst us, we've got GFF country coordinators here from Tanzania, from Zambia, from Zimbabwe, from Kenya, and they are also, we're very honoured to have with them representatives of their governments keen to learn how to bring SBBC to countries in this region. So thank you for having us, and really look forward to the day. Thank you very much.
Asante. As you took note during the introductions, we have multiple African countries here. But I just want also to say that we have our Association of EXA, East Central Southern Africa, represented as well, all the way from Arusha. So we are covered. Those countries that do not attend, they will get a message. So now I welcome my co-moderator, Beatrice, to really take up the next session, where we'll have some insights and remarks from our local collaborators promoting maternal newborn and child care. Karim.
Good morning, dear delegates. Protocol observed as mentioned earlier. And before I welcome the local partners, I would like to give a short orientation of our conference. On my left side to the back, we have a washroom, so you can rectify your tie or your lipstick. And on the middle door, you can access refreshments. We have coffee and some other stuff, so don't feel dehydrated or hungry at all. Thank you. And the last one, I believe all of us listed as the next entry. So now I call upon our local partner from Newbury. Newbury representative. Welcome, Dr. Gregory.
So good morning, everybody. First of all, I'd like to thank you on behalf of the National Medical Research, the organizers of this event, for inviting us to come here, basically to learn, to celebrate the success that we've made, and continue to support you. NIMRE is a research institute, does a lot of work in that is here that improving both child and maternal health. And coming here to see what you have done is really a great opportunity to learn from you. And we certainly, as an institute, continue to partner with you, support you, ensuring that you achieve the objectives for which this project is targeted to. Thank you very much, and welcome to me.
Thank you so much for observing time. I did not mention we have a maximum of 2 minutes. 3 minutes is stated. Next is I am Child, and after that I'll call upon the MMI representative. Thank you.
Good morning, everyone. My name is Murati Masanja. I'm the director of the Fakara Health Institute, but also the NEST 360 country lead. I'll speak here about NEST because NEST and SBDC are complementary programs. So NEST is an alliance it's an international alliance of clinical, biomedical, and public health experts from 23 leading institutions and organizations. So our model, the NEST model, is to support governments to deliver and sustain a package of affordable technologies for small and sick newborn care, and to develop an education ecosystem that prepares clinicians, biomedical technicians, and students to support small and sick newborn care and foster innovation. The third pillar of NEST is to support countries to implement evidence-based care for small and sick newborns and make investments case to sustain quality care. So NEST is currently operating in 5 countries: Tanzania, Kenya, Malawi, Nigeria, and Ethiopia. So I'm happy to hear my colleagues from Nigeria. I'm sure you know about NEST in Nigeria. So NEST and the SBDC really complement each other because SBDC is in the maternity ward, but NEST is in the newborn ward. And sometime this year, we'll probably start a program that will be linking these two interventions, which I think will have a bigger impact and save more newborns, but also save the mothers. Thank you.
Thank you very much. MMI representative. Dr. Joseph. Dr. Joseph M. Mama representative. I understand Dr. Rashid has his presentation.
Good morning. All protocol observed. I would have loved to have the government representatives speak about Mama, because we, implementing partners of Mama, handed over the program to the government almost 7 months ago. But we're working very, very good collaboration with the government, so I'm also part of the government, so I'm happy to speak about Mama. Thank you for giving me this opportunity, and Mama is an intelligence transportation program. It addresses the 3 P's in accessing care, and it complements very well with the work which is done through the SBBC. While the SBBC is focused mainly on quality of care, quality improvement, making sure that services of high quality, Mama is facilitated to make sure those who need services can access the services on time. And we are exploring the opportunities of expanding Mama to other countries. We are already working in Lesotho. We are currently initiating the program in Malawi, and we are exploring opportunities for working together in other countries. Thank you so much, and I wish you a lovely meeting.
Thank you, Dr. Joseph. And now I call upon Tama representative, Dr. Davis. And after that, I'll call upon Agota representative, Dr. Sani. Please be ready.
Good morning, everyone. I'm Dr. Murike, I'm a medical specialist, and I work as a lecturer at Miguru University of Ethical and Sciences, and I am the president of the Tanzania Midwives Association. I'm really grateful, and I would like to applaud the SPBC team, the coordinating team, for the amazing work that they have been doing in ensuring that they control and reduce the maternal and newborn mortalities in the country. And TAMA, as the voices of midwives and as a professional association, we have really been committed and work hand in hand with the SBBC team to ensure that midwives are capacitated, they become competent for them to be able to provide care to our mothers and newborns. Thank you so much for this opportunity, because I've actually just noticed this morning that I was supposed to give some remarks. But I would really appreciate all the contributors who have been able to ensure that we reduce the maternal mortalities. And Tanzania has been like a kind of an example to other countries in sub-Saharan Africa and in low-income countries in ensuring that we have been able to reduce for about 75% of maternal mortalities, which is a great milestone. And I believe we are going to reach the SDG goal that is intended to reduce the maternal mortalities to at least 70 maternal deaths per 100,000 live births. Thank you so much.
Dr. Sandra, please come forward.
Good morning. Habari za asubuhi. Wish to recognize the charitable leaders from MOH, led by my brother and mentor, Dr. Ahmad Magwani, Director, Pure Right, Health, Nutrition and Social Welfare. Wish also to recognize relatives from our development partners, implementing partners, RHMTs, and everyone. I cannot mention because of the limitation of time. My name has not changed, Sandy Dominico. I'm the president of Association of OBGYN in Tanzania, Agota, a certified voice representing an army of OBGYN in the country for the welfare and well-being of women as well as adolescents. But to set the stage clear, I also wish to introduce the other affiliations. I'm also the Director of Programs at Thamini Wari, a local NGO working on maternal health, but very strong affiliated with the Ministry of Health. I've been part of the team for 4 years, coordinating MPDCR among other roles, although that role is transitioning now. So it's a real honor and a pride to be here as an invited participant to this wonderful forum. So Agota has been a proud partner of SBBC throughout the inception, conceptualization, design, implementation, as well as dissemination. As Agota, we strongly believe in partnerships and collaboration as key ingredients in walking the talk, in implementing global, regional, as well as national commitment on maternal, newborn, as well as child health. I cannot remind you of the commitments, but everyone knows about the journey that we are all targeting, the SDG 2030. Only 5 years down the line, we are also aware of our local commitment, including 1 Plan 3 and the like. It's only through shared vision, mission, as well as partnership and collaboration we can walk the talk. At Agota, we stand for professional care for women, adolescents, and we do believe in that mix. Certainly, initiatives such as SBBC, which are bringing us evidence-based interventions to the grassroots, testing, implementing, and then sharing for others to learn and continue to scale, is all that we want to see. So on behalf of Agota, we are happy to engage, continue to contribute, and to make sure that we take the targets, the local and the global targets to fruition. Asante sana.
Thank you very much, Dr. Sani, for closing for us this chapter. And now I call upon the SBBC team for SBBC salutations. We have a salutation that says that maternal and newborn deaths are unacceptable, so let us come together and eradicate them. So if you know the greeting, you can also join us. We are going to demonstrate first, and you can also join us. Thank you. SBBC team.
So when I say hello, we should all stand up and say the word you're going to be shown, but let us demonstrate first. I'm taller than all of them, so let me just stand here. Hello?
Yes. Vifo vya watoto wachanga, vifo vitokanavyo na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
So let us do this together, okay? No, when I say hello, you say yes while standing up, okay? Hello?
Yes. Vifo vya watoto wachanga, vifo vitokanavyo na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
Let's do this once again. Hello?
Yes. Vifo vya watoto wachanga, vifo vitokanavyo na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
Please give yourself a loud applause.
So, thank you so much, Beatrice. Now we're going to the kind of official opening. Before we go to the official opening, that will be facilitated by the Executive Director of FIDOM. I would like to invite a representative from Gates Foundation to come and say a word, and then we'll have someone from Chai Global to also say, you have just 2 minutes to have your remarks. Gates Foundation representative.
All right.
Good morning, everyone. So my name is Emi Suleiman. I work as a program officer for maternal, newborn, child health and nutrition at the institution. All right. So the director of family health in Nigeria has already given the opening remark on behalf of the government in Nigeria, and of course, the Gates Foundation in Nigeria was supporting the government of Nigeria in eradicating maternal mortality in country. So overall, I bring greetings to you from the country director of the Gates Foundation Nigeria, Richard Amon, and also the deputy director, family health, Rudy Diallo. So generally, we are here to learn and see how we can replicate and also adapt to the learnings from Tanzania back in Nigeria. So it's my pleasure to be here, and good morning.
Global.
Hi, good morning everyone. All protocol is really observed. I would like to just follow in the steps of everybody before me to thank the organizers of this meeting for the opportunity to be here. CHAI has partnered with LIDA for at least the past 10, 11 years, if I recall. We've always, bought a lot of the devices. We've been working to really scale up these cost-effective tools across several countries where we work. And so it's a real pleasure to be part of this transformative opportunity to scale up SBBC, not only in Nigeria, but to several other countries. And so I applaud everyone for the great work. I'm really impressed by what I've met here at HIDOM, and we really look forward to partnering with the Federal Ministry of Health and Social Welfare of Nigeria to scale this up in our country and beyond. Thank you very much.
Thank you so much. Now we welcome Dr. Ndoye to facilitate the welcoming of the PLR representative for official remarks.
Thank you very much, Dr. Castan, and thank you for the well-organized sessions that has just finished. And my work here is to welcome the government officials, and to start with, I'd like you to tell you a little bit about the Director of Health, Nutrition and Social Services from the President Office, Regional Authority and Local Government, Dr. Rashid Fowler. He is a well-experienced man who has been working with the government for many years. He is a medical doctor, expert in primary health care, but also expert in public health services. He has worked in the government in many positions, starting from the very lower position as a DMO, but he has worked many years as a regional medical officer in many areas, but also he has been working for the President Office, Regional Authority and Local Government for many, many years. So he's a fit man for the discussion when it comes to scale up. And in Tanzania, you may wonder, in health, we have two ministries working on that area. We have the President Office, but also we have the Ministry of Health. So the two men here today, they will tell us the difference and what is the demarcation between the President Office and the Ministry of Health. It's my duty now to welcome Dr. Rashid Fowler. Please welcome for giving us remarks from the President Office, Regional Authority and Local Government. Karibu sana daktari.
Good morning, everyone. Let me introduce myself again. I'm Rashid Mfaume. So my position at the Ministry of President Office, Regional Social Government Authority, is the Director of Health, Social Welfare and Nutritional Services. But I'm standing here today to represent the Permanent Secretary, President Office, Regional Administration, Local Government authorities. Before going directly to my remarks from the government side, from the PRR, I'm really honored to take this opportunity to recognize the presence of the Assistant Bishop and the continued cooperations that is ongoing, especially with the primary care between the faith-based organizations and the government, especially the PRR, but also the chief guest and all the already introduced participants. For the interest of time, allow me to say that the protocol has been observed. So, as I said before, and let me take you to just in a brief, to tell you the mandate of the President's Office, Regional Administration Local Government in Tanzania, for the interest of those who are coming outside of Tanzania. The setup is, we have the Minister of Health, that is a sector minister, and the chief guest may have time to explain, but its mandate is really the policy formulations, but regulatory and legal framework formulations as well, but providing strategic directions. And we as the pure line now is ensuring that the strategic visionary documents, guidelines, policies, strategic documents are correctly put into implementations at the subnational levels, at the regions and the local government authorities. In the context of SaferBirths band of care is ensuring that and coordinating actual implementations of the interventions through the regional health management teams, but supervising closely the local government authorities. So I thought it's very important to introduce or to start with that opening statements. But actually, as a pure light, we understand that it's both an honor and a privilege to address you today on a matter that lies in every part of our national health agenda. Primary health care, as you all know, on behalf of the Pure Light, it has been our unwavering commitment to strengthening the primary health care as the foundation of Tanzania's health systems. The primary health care is not merely a type of services delivery alone. It's the most equitable, efficient, and effective pathway to achieving universal health coverage. The good thing with Tanzania, we have already passed a national act and its regulations on universal health insurance towards universal coverage. It is therefore, health begins and where lives are saved. The PHC is a platform for maternal and neonatal health. It's addressing that we have made significant steps in reducing the maternal mortalities. When you look into the data of the Tanzania demographic and survey data of 2015-2016, that I think will be explained in more detail by the guest of Anna. We have made a significant achievement in terms of reduction from 556 per 100,000 live birth, 104 per 100,000 live birth. That's a significant achievement. Having that achievement is one thing, but sustaining the gain is another important matter. But still, we are not done enough in reducing the neonatal mortality. When you compare the same survey data from 2016 as that of 2022 survey, the neonatal mortality reduction is not something promising. It's only from 25 per 1,000 live birth to 24. So this is really, there's a work to do. And one of the intervention we are the Pure Life that we really support, and we are always committed to work on it through the SBBC initiatives. So maternal and neonatal is the cornerstone for PHC in Tanzania. And let me tell you that over 70% of births occur in the PHC. This data could be similar to other data in other African countries, but this is for Tanzania services. And with increasing political commitment for excellence president, increasing constructions, equipping, recruitment of human resources for we have seen evidence the increase in the utilization of health services, the use in the barrier access services and the infrastructures are now closer to the household. So even the number of household members not only accessing services but accessing the quality services has increased tremendously. This statistics is not just a number. It is a call to action. It compels us to ensure that these facilities, there are new facilities that are not equipped by 100%, but a lot of work has been done, but we still have a joint efforts to see how can we equip the facilities with the necessary tools, with the necessary skilled staff, and appropriate by strong systems. Every mother and newborn deserves a quality care, regardless of where they live. And we at the Pure Life, we have the quality, the healthcare quality implementation roadmap. For those who are interested, we can share it, but the Minister of Health are the guidelines, the framework for quality, but we as we are implementing the interventions, including the quality improvement initiatives, it's our mandate now to formulate the implementation roadmap, including the quality implementation roadmap, and that we have done in that area. So SBBC are the PHC driven innovations. We take it as driven innovations. The SaferBirths Plan of Care initiative represents transformative innovations deeply rooted in the PHC settings. SBBC is not a parallel program. It is a catalyst for change within our existing infrastructures. With the implementations arrangement in over 140 PHC facilities currently, but the good thing that the best approaches, we can see even other facilities not within the project coverages have led and started gradually implementing some component of the interventions of the SBBC. So SBBC has proven its scalabilities, relevance, and potential to reshape maternal and newborn care in Tanzania. So the impact of SBBC on the PHC outcomes, I think from the surveys, we have seen, as I've mentioned them later, but also from the applications and the progress of outcome indicators of the projects, the experts, the investigators have shared with us. But through SBCC, we have witnessed a tangible improvement in the facility readiness. Simultaneously, there's training as immensely critical competencies, but equipment provisions as filled critical gaps. Mentorship has fostered a culture of continuous learning and a quality improvement. And we as a Pure Life, it's our role also to see this really happening in line with our national guidelines. So
whatever interventions is being implemented, it's our role to ensure that it is implemented as per the guidelines. So we conduct the supporting supervision. And as the director, I had the chance several times to visit the facilities and also to have a dialogue with the community to see their perception towards the SBBC, and the response was promising. So integration with the PRI authorizations. SBBC aligns seamlessly with the PRI strategies, priorities. It empowers regional and council health management teams to read with data. And that's very important in evidence-informed decision making, act with the confidence, and deliver with impact. Our regional medical officers and reproductive and child health coordinators who are here from 5 I'm happy that we have regional medical officers and regional reproductive and child health coordinators from Manyara, Tabora, Shinyanga, Mwanza, and Geita. These are the presentation structures of the President's Office, Regional Administration of Government. But below that, we have the council management teams. And this decentralized nature is under the law of Tanzania. We call it decentralization by devolution. The central government cannot do each and everything. So decentralize the function of the central government to the lower levels. Lower levels in terms of governance, structures, in terms of oversight and technical laws. Data-driven decision making is very important. The key strength to our opinion as a PLI, the key strength of self-based plan of care lies in the integration of digital tools. These platforms have enhanced data visibilities, accountabilities, and responsiveness at the primary healthcare facility levels. I urge all stakeholders who are present here today to embrace data, not just as a reporting tool, but as a driver of local solutions and smarter resources allocations. Before I conclude, however, allow me to mention a few key issues on the sustainabilities and the scale-up. This is very important, and sustainability agenda is not an agenda of partners alone, it's an agenda of all of us. Sustaining and scaling up the gains of SBBC, we must continue investing in the PHC, whether we like it or not, and I will tell you why. This means integrating the SBBC into the national health strategies and budgets. Just before I came to this meeting, I went through the data for 2024, the annual data. We collected data from January to December, our national health management information system data through district health information system version 2. When you look into the institutional deliveries annually for that year, it was around 2.2, that's around on average 2.2 million. And those who delivered at the primary health care, mothers who delivered at the primary health care, accounted for around 2.06 million. This is equivalent to 93%. That's why if you are talking about sustainability, if you are talking about embracing the gains through the SBBC, we must invest technically, we must invest materially, we must invest politically, we must invest financially through the primary care. I'm not saying that we don't really specialize the care, don't quote me wrong. But also when you look into the data for the antenatal clinic, the first visit, for the same year, I'm talking about the data not from my head, from our official data management systems. first and C visits were around 2.7 million annually, January, December 2024. Out of that, 2.6 million were attending at the primary health care facilities. And definition of primary health care facilities in Tanzania, those who have been attending at the dispensary is like the lowest level of care in the communities. Then we have the health centers, we have the cancer hospital. Then we have the hospital at the district level, coming below. So first in C amounted to 2.6 million. This is equivalent to 97%. 97%. I'm not saying this because I'm standing at the podium, because I'm representing PLR. This is the fact. Most of our beneficiaries, when you're talking about SBCC, are from the primary health care. And they are accessing services at the primary health care. So whatever we're discussing here at the stakeholders meeting, please, the initiatives. I'm not saying that there is no need of the other level, but let's think the data have to guide us in terms of decision making, whatever we're discussing. Our discussions, our conclusions, our recommendations, our M&E systems should be informed by data. That's what I'm emphasizing here. But when in the same period, January, December 2024, users of modern family planning methods, annually the data was 9.4 million. Out of that, 9.2, which is equivalent to 98%, we are accessing these services of family planning methods at the primary health care level. I cannot go to all data sets. I'm just selecting a few to show the picture and the importance of the primary health care. The primary health care is the game changer when we are talking about investments and the buildings asset. And even when we're selecting now, we are celebrating about 140 facilities that we have in this project. But out of more than 10,000 facilities that we have in Tanzania at all levels, from the primary to tertiary level, more than 70% of the facilities are the primary health care level facilities. So I think those few data sets are enough for the interest of time. But when you go across so many data, you can see our discussions should be guided in terms of the data. And as we have seen SBCC as that concentrations, because we have seen those efforts addressing the changes, the game changers through the primary health care. But let me just conclude by mentioning a few initiatives in terms of the government of Tanzania, especially the primary health care. In addressing 3 delays, the first delay in maternal and newborn mortality, second delay, and the third one, we have an initiative of emergency transportation system through a mama. My brother Joseph Kamwangula has spoken to very well. And since 2022, April, this program is not a program of the implementing partner or the donors. It's already taken by the government. And the government is now running this program but with the technical support from our partners. And a lot of lives have been saved. So that's the good thing with the Mama program. A lot of lives have been saved. And with other interventions delaying the third delay, for example, a lot of infrastructures, equipment, employment, trainings, essential commodities for life savings are being procured and equipped at our facilities. The ongoing health promotion activities are ongoing to address the first delays. But as a pure large and as the government of Tanzania in general, in terms of sustainabilities, let me assure our implementing partners, our donors, that politically, in terms of political sustainabilities, as you can see, we have the strong political sustainabilities or political commitments at all levels, including the political commitment of Excellency President Samia Suluhu Hassan herself. But when you go to the ministers, both Minister of Air, Deputy Ministers, Minister of State, pure large, when you go to the regional levels, to the district levels, so in terms of the political commitment and the political, when you're talking about sustainability, my friends, colleagues, you should not concentrate on funding alone. There are other factors that are very important when you're talking about sustainability. But community engagement, I think, you can see, and through discussions, very important. And we as a pure large, that has been our role, engaging communities in this SBCC, in other interventions as well, but also sustaining the problematic sustainabilities, sustaining these gains that we see as achievements through SBCC projects. That has been our priority as well in terms of, but in terms of funding, we're also making use of digitalizations. We have the support government of Tanzania, the Gold Office, government of Tanzania Information Operation Systems. We are apart from capturing the primary health care data, the medical record systems, but also has increased accountability in terms of revenue collections, the appropriate expenditures, and the efficient use of the revenues, including funding for reproductive, maternal, newborn, and childbirth interventions. So that's very important to have local available revenues, commitments, and accountabilities. So I know I've taken a lot of time, and the chief guest is waiting to provide his speech. So let me finish really by delivering our commitment at the President's office. And the ministry that I'm coming is under the President's herself. That's why it's called the President's Office, Regional Administration and Local Government Authorities. And the minister is called the Minister of State, responsible elected under the President. So the commitment, transparency, accountability is our priority at the ministry. So be assured, the implementing partners don't want every cent, every initiative. That is assured to be accounted effectively, openly, with a full accountability. Let us champion PHC, primary care, are the engine of health system transformation. Let us work together, governments, partners, and the community, to scale SBCC to every region of Tanzania. Let us ensure that the mother or newborn, that no mother or newborn is left behind. And most importantly, quality care should be a privilege. It must be an assurance. Thank you very much for your attention. Thank you very much for listening.
Asante sana Dr. Rashid Mfaume. A big applause for you. Yes, he has highlighted very important things. First of all, SPBC is a catalyst for change. But also data is key to inform any decision. I agree with Dr. Mfaume that more than 90 to 96% of all the facilities that SPBC is working on is under primary health care. So in SPBC, out of 142 facilities, 137 facilities under his ministry. So we really work for this big group. Thank you very much, Dr. Faume. You have answered some of the questions of members here about scalability and sustainability. So I know that we will have few questions on sustainability because most of these has been answered. Yes, now is the time to call upon the chief guest, and we invited the permanent secretary from the Ministry of Health to be a chief guest for this important meeting. And he has delegated that to the Director of Reproductive and Child Health from the Ministry of Health, and this is Dr. Ahmed Makwani. Let me tell you a little bit about Dr. Ahmed Makwani. He is my mentor. He is a prominent figure in the Tanzanian health sector. Most of you have heard about him. He's serving as a Director of Reproductive, Maternal and Child Health in the Ministry of Health. And his role in the Ministry of Health, he has been instrumental in shaping reproductive, maternal and child health policies in Tanzania. He has worked closely with international organizations like Global Financing Facility, GFF, they know him very well, UNFPA, to improve access to family planning, services, maternal health commodities. He has been advocating and has emphasized the importance of newborn health, citing the nearly half of child mortality occurs in the first month of life, and therefore most of the intervention he promoted them to support this area. He has several collaborations. I don't want to tell you all of his CV, but let me invite him to the podium to give us a key opening speech. Karibu sana Dr. Makwani. A big applause for him when he comes.
Good morning to everyone. Good morning. As I've been introduced, my name is Dr. Ahmed Makwani. I'm currently serving as the Director of Reproductive, Maternal and Child Health Department at the Ministry of Health. I'm standing here representing the Permanent Secretary who is in a mission outside the country. And I wish I could have delegated this matter as well we could have delegated this matter as well to the Regional Administrative Secretary, just to let later that she was part of the delegates accompanying the Honorable Vice President. So finally it fell to me and I had to take the responsibility. So, receive sincere greetings to the PS who was determined so much to be part of this meeting, but because of the mission going outside the country, he was unable. Dr. Rashid Mfaume, Director from PRI, Dr. Felix Budara, the Assistant Director from my department, Mchungaji Johnny Nade, ambaye ndio anamwakilisha askofu wa kanisa la Trinitarian from Buru Diocese, I'm supposed. And the chair of the board of Haydon Hospital, Dr. Peter Maluki. Waganga wakuu wa mikoa na halmashauri wote mlioko hapa ndani, directors from different institutions, the head from NIMRI, IHI and others, presidents from professional associations, Dabota, Tama, Tana, and PAT, and the others, representatives from UN, WHO, and UNICEF, distinguished guests from outside the country. I understand we have people from Norway, I saw some few, Nigeria, I suppose we were expecting also people from Zambia, Zimbabwe, Cameroon, Kenya, and Uganda. I'm sorry if I'm not mentioning your country that is present here as well. Institutions from outside the country, I understand there are teams from Label, the Foundation, GFF, and the others. Healthcare, my fellow healthcare providers, media crews, distinguished guests, ladies and gentlemen. My speech has been prepared in Swahili because finally it goes to the people of the United Republic of Tanzania. So I'm asking those seated close to foreigners, please support the translation where possible. But I think Dr. Bishanga will be here also going with me to translate this speech. Jamhuri ya Muungano wa Tanzania. Awali ya yote napenda kumshukuru Mwenyezi Mungu mwingi wa rehema kwa kutufikisha na kuwa hapa salama katika kushiriki mkutano huu unaolenga ajenda muhimu sana kwa taifa letu.
So I thank the Almighty God for enabling us to be here this morning to discuss a very important agenda for our country, which is maternal and newborn health.
Ajenda hiyo ni utoaji wa huduma ya afya uzazi, mama na mtoto. Ninayo heshima kusimama mbele yenu katika mkutano huu muhimu ili kuakisi dhamira yetu ya pamoja yenye nia ya kuboresha huduma za afya uzazi, mama na mtoto.
My presence today here reflects on our joint commitment to improve the health of mothers and newborns.
Ninapenda kuchukua fursa hii kuwakaribisha wageni wote ambao mtashiriki katika mkutano huu. Nimetaarifiwa kuwa kuna wageni kutoka nje ya Tanzania ambao wanatoka katika nchi za Norway, Nigeria, Kenya, Zambia, Zimbabwe, Cameroon na Uganda. Na huenda wapo wengine kutoka nchi za nje.
I take the opportunity to welcome all the invited guests, from particularly those coming out of Tanzania, for the countries that have been mentioned, and you are warmly welcome.
Aidha, nimeona na nimeshuhudia kuwa wapo wawakilishi wa mashirika ya kimataifa yanayojishughulisha na masuala ya afya, hususani masuala ya afya ya uzazi, mama na mtoto, ambapo nimeona washiriki kutoka UNICEF, GFF, NCA na Label Foundation. Aidha, mpo wageni kutoka nje ya mkoa huu wa Manyara, kutoka serikali kuu, idara ya afya, ofisi ya Rais TAMISEMI wakiongozwa na Dr. Rashid, mashirika ya serikali, vyama vya taaluma na wawakilishi wa watoa huduma hapa nchini. Napenda kuchukua fursa hii kuwakaribisha wote katika mkoa wetu wa Manyara, na mpatapo nafasi basi mkipata nafasi basi mchukue fursa hii pia kutembelea vivutio vyetu vya Tanzania ambavyo haviko mbali sana na mkoa wetu wa Manyara. Nadhani vivutio vyetu tunavijua, kuna Ngorongoro, kuna Serengeti, kuna Manyara yenyewe, ya Manyara na zingine nyingi ambazo unaweza kutembelea, lakini msisahau pia mkitoka hapo twende tukatembelee sasa. Asante.
So I've organized different groups of partners who are here, international organizations that have been mentioned, professional associations, people from outside of the Manyara region, particularly from the central government, including POLAC and everyone. You are invited to the Manyara region, and as you attend this meeting, don't also forget to take time to visit some touristic attractions within the reach of this region.
Lengo la mkutano huu ni kukutanisha wadau wote wa afya ya uzazi, mama na mtoto, ili kujadili machapisho ya sayansi na hasa hususan lile chapisho ambalo limetoka kwenye New England Journal ambalo linaonyesha jinsi gani kitita cha uzazi salama, yani SSSP bundle, kimefanya vizuri katika kuleta huduma kwa wananchi. Utekelezaji wa kitita hiki wa awamu ya kwanza ulifanyika katika vituo 30 kutoka mikoa ya mitano ya Manyara, Tabora, Mwanza, Geita na Shinyanga. Katika awamu ya pili iliyoanza Disemba 2023, mradi huu unatekelezwa katika vituo vya afya zaidi ya 140 ndani ya mikoa hiyo. Kwa hiyo tutapokuwa hapa tutakuwa tunaangalia ni namna gani tumepiga hatua kwenye kitita hiki.
So we are convening here today to just celebrate and review the impact that we have seen with the SBBC implementation in Tanzania, particularly the project outcomes that was documented or published in the New England Journal. And the new phase of this project covered 30 facilities in 5 regions, and then the second phase is now covering over 140 health facilities in the same 5 regions.
Bibi na mabwana, ninayo furaha kuwa hapa tulipokaa ambapo ni Hayo ipo katika mkoa wa Manyara. Na Hayo ni sehemu ambayo ilikaliwa na ndugu zetu wa Norway enzi hizo, na hawaisahau. Wakija tu Tanzania, they know, people from Norway, when they come to Tanzania, they know their home is Hayo. And I would like to take this opportunity to welcome you again to Hayo. Lakini kubwa ni kwamba katika huu mkoa wa Hayo, katika mkoa huu wa Manyara, imekuwa ni mmoja wapo kati ya mikoa ambayo imebenefiti katika zile huduma ambazo zinapewa na SBCC bundle. Nichukue fursa hii kushukuru taasisi ya Landell Foundation pamoja na wenzetu, washiriki wenzetu ndani ya Wizara ya Afya na ORA Kamisemu kupitia hospitali ya Kiluteri ya Hayo kwa kushirikiana pamoja kuhakikisha mradi huu unatekeleza katika mkoa huu na mikoa mingine, na hivyo kutia chachu katika kuchangia matokeo makubwa ya kupunguza vifo kutokana na uzazi na vifo vya watoto wachanga. Aidha, serikali inapenda kushukuru vyama vya kitaaluma ambavyo ni pamoja na chama cha madaktari bingwa kwa watoto party, if you can raise your hand, chama cha madaktari bingwa wa magonjwa ya wanawake na uzazi Tanzania AGOTA, na chama cha wakunga Tanzania TAMA, vilivyoweza kushirikiana bega kwa bega katika utekelezaji wa kitita cha uzazi salama. Tunawashukuru sana.
So we as a government, we do commend the partners that have really taken part in the implementation of SBBC, LEDO Global Health, and the LEDO Foundation, the Haydon Lutheran Hospital, all the professional associations, and the ministry agencies and the Ministry of Health and the POLAC for implementing this project in Manyara and the other regions.
Ladies and gentlemen, I take note of the significant progress that is being recorded by Tanzania. That shows that the maternal mortality was reduced from 556 per 100,000 live births, reported which came out in 2015, by 80% to 104 births per 100,000 live births, a report which came out in 2022. I also would like to record and take note of the progress made by our country of reducing the under 5 mortality from 67 deaths per 1,000 live births, a report which came in 2015, to 43 deaths per 1,000 live deaths at court, which came out in 2022. However, there was no statistical significance which showed a reduction in the newborn mortality, which showed that there was some stagnation, whereby we recorded 25 per 1,000 live deaths in 2015 and 24 per 1,000 live deaths in 2016. So to say, the SBCC ban may be one of the complementary in this area to address the newborn mortality. Mabibi na mabwana, matokeo ya hapo juu yanatia moyo na nguvu kwa nchi yetu kwamba uwezo wa kufikia malengo endelevu ya milenia ya mwaka 2030 ya kupunguza vifo vitokanavyo na uzazi kufikia chini ya 70 kwa kila kizazi hai 100,000, vifo vya watoto walio chini ya miaka 5 kufikia chini ya 25 kwa kila kizazi hai 1,000, na vifo vya watoto wachanga kufikia chini ya 12 kwa kila kizazi hai 1,000, jambo linalowezekana. Lengo hili tunaweza kulifikia kupitia jitihada zetu kama nchi na kuweka ushirikiano pamoja na wadau wetu wa maendeleo wa ndani na nje ya Tanzania. Na mfano mzuri tumeuona jinsi gani Norway kupitia SaferBirths wameweza kutusaidia kwenye hili, na si ajabu pia wengine wataungana na sisi katika eneo hili. Lakini pia tumeona complementers wengine, kwa mfano IHI ambao pia wamekuwa wanatusaidia kwenye eneo hili, na sasa hivi katika zile intervention ambazo tunaangalia innovations zilizoko katika newborn care, lakini pia kuhakikisha vile vifaa tunaweza kuvitunza vizuri, wamekuwa ni complementary. Na nichukue fursa hii kuwaomba wadau wengine kuungana na sisi katika marathon hii ya kupunguza vifo vitokanavyo na uzazi, lakini hasa vile vifo ambavyo vinaonekana vimestagnate ya newborn.
So, dear colleagues, the progress that the country has made in reducing maternal and neonatal mortality is encouraging, although we still need to do enough. And as the government of Tanzania, we are calling upon partners who have been working with us, including Lead of Global Health, IHI, and I don't Lutheran Hospital, to continue working with us as we are likely to achieve the Sustainable Development Goals by 2030 if we join our hands.
Bibi na mabwana, tumejifunza kupitia uboreshaji wa huduma za kina za dharura za afya uzazi na watoto wachanga SEMO kwamba ukifikisha huduma karibu na wananchi, kuna uwezekano mkubwa wa kupunguza vifo, hususani vifo vitokanavyo na uzazi na vifo vya watoto. Mwaka 2020 Juni, Tanzania ilikuwa na vituo vya afya vinavyotoa huduma za SEMO 330. Hiyo ndio ilikuwa rekodi. Ukilinganisha na vituo vya afya 576 vinavyotoa huduma hii kufikia Mei 2025 wakati inasomwa bungeni. Na hivyo kufikia wananchi 85% wakipata huduma karibu ndani ya kilomita 5 kutoka majumbani kwao. Hivyo kwa kutumia mfumo huu ndiyo marathon ambayo Tanzania inatembea nayo kuhakikisha kwamba huduma za watoto wachanga hususan kuwa na neonatal care units zinawekwa karibu na wananchi, na our denominator tunayotembea nayo kwa sasa hivi ni hospitali za halmashauri.
So the government of Tanzania is committed to bring the services closer to the people, as by this year over 85% of Tanzanians can access health care within 5 kilometers. And we have increased the comprehensive emergency obstetric and newborn care centers from 330 in 2022 to 576 in 2025. The same, we have also been able to increase the number of neonatal care units, and our intervention units for now is for all district hospitals to have neonatal care units.
Ladies and gentlemen, we take note that we failed to reduce neonatal mortality simply because we did not have an address for the newborn care. And that address is having neonatal care units. We take note, in 2018 we had only 14 recorded neonatal units. And currently we have jumped in, and the data will be shown later, that we have made a marathon and we have reached the amount of 362 units of that kind that provides service. Nilichokuwa nasema kwa wale ambao Kiswahili inakaa pembeni, Kiingereza kinakaa pembeni, vifo vya watoto wachanga vinaonekana kupungua kwa kasi ndogo kutokana na kukosekana kwa wodi maalum za kutolea huduma kwa watoto wachanga wanaozaliwa kabla ya wakati na wenye uzito mkubwa. Kwa kuzingatia mwenendo ule wa kuwa na huduma karibu na wananchi, Mheshimiwa Dr. Samia Suluhu Hassan, Rais wa Jamhuri ya Muungano wa Tanzania, wakati akizindua matokeo ya utafiti wa watu na viashiria vya afya Tanzania Demographic and Health Survey 2022, aliagiza kuhakikisha kuwa tunawekeza kwenye upatikanaji wa neonatal care units katika hospitali zote za halmashauri. And we have seen the President quite often visiting our facilities, specifically to neonatal units, and talking with providers as well. That has been a huge encouragement. Katika kutekeleza agizo hili, mwaka 2022 Tanzania bara ilikuwa imeanzisha NCU 175. Na sasa taarifa zinaonyesha kuwa tuna NCU 362, which is double the number of 175 which was reported in 2022 to 362 in 2022. Tunadhani uwepo kwa vituo hivi utakuwa ni game changer kupunguza vifo vya watoto wachanga. We have heard from these neonatal units very good stories. A 600 kilograms baby surviving to 1 kg, surviving to 2 kg, and getting a discharge. Before that, a 600 gram, by our definition, is an abortus. Is an abortus, would have been neglected and died there. But because we have the neonatal care units and the kangaroo mother care rooms, we have managed to groom these babies and they've survived. Our ministers, when they visit various facilities, they get those stories. You can see them, how they smile in terms of these results. These are the results. You can clap for these results. Mabibi na mabwana, mapitio ya vifo kutokana na uzazi na vifo vya watoto wachanga yanaonyesha kuwa swala la upatikanaji wa watoa huduma wenye ujuzi na weledi katika utoaji huduma, uwepo wa uongozi imara katika vituo vya huduma, upatikanaji wa vifaa tiba na dawa hususan kwenye NCU zetu ni mambo ambayo tunahitaji kuyafanyia kazi ili kuleta matokeo makubwa. Hivyo ni matarajio yangu kuwa kikao hiki cha leo kitajikita katika kujadili masuala haya kwa kina. Kumbuke maneno ya baba wetu wa taifa Mwalimu hayati Mwalimu Julius Kambarage Nyerere, rais wa awamu ya kwanza, alisema ili tuwe na maendeleo tunahitaji watu, siasa safi na uongozi bora. Hivyo ili kupunguza vifo kutokanavyo na uzazi na vifo vya watoto wachanga, tunahitaji kuwekeza kwenye ueledi wa watumishi na uongozi bora. Tukiweza kutekeleza haya, rasilimali tunazowekeza zitakupatia matokeo tunayoyataka.
Ladies and gentlemen, through our maternal and prenatal death reviews, it has indicated that to be able to address maternal and newborn mortality, we need to invest into infrastructure, equipment, and the supplies of commodities as well as number and the quality of healthcare workers. Quoting the first president of Tanzania, Julius Kambarage Nyerere, that development needed people, enabling political environment and good governance. We should now invest into our people, making sure that healthcare workers are competent, as well as ensuring we have good leadership for health services.
Mabibi na mabwana, naomba nichukue fursa hii kuwaomba wadau wetu wa maendeleo kuendelea kufanya kazi na serikali ya Jamhuri ya Muungano wa Tanzania inayoongozwa na Mama Samia Suluhu Hassan, our known champion for reproductive maternal and child health, katika kuboresha huduma za afya mama na mtoto hapa nchini kwa mafanikio mapana ya nchi yetu, lakini na bara letu la Afrika na duniani kote.
Our President, Dr. Samia Suluhu Hassan, is known as a champion for maternal and newborn health. Hence, we make a call to our partners to continue working with the government of Tanzania to make sure we have a better health of women and children in this country.
Mabibi na mabwana, ikiwa naelekea kuhitimisha hotuba hii, naomba nichukue fursa hii kutoa shukrani zangu za dhati kwa hospitali ya Kilutheria Haydom na Ladel Foundation kwa kutuheshimisha kwanza kwa wenyewe, manake hospitali yenyewe ilipo tumeona jinsi kulivyo mbali na very remote. Kwanza kuheshimisha mkoa wenyewe, lakini kuheshimisha Tanzania kwa kuita watu kutoka sehemu mbalimbali za dunia hii na kuja kusikiliza nini Tanzania inafanya. Tunawashukuru sana. Ninaomba matokeo ya mjadala huu sisi kama wizara tuyapate, lakini pia sio vibaya matokeo ya mkutano huu yakafika kwa rasi ambaye alitaka kuja hapa pia, ili tuweze kuyafanyia kazi mapema na yale ya kitaifa tuyapeleke juu kwa ajili ya mpango wa kitaifa. Kwa hiyo tunatarajia tutapata ripoti hii mapema sana.
So it is a great honor for the region of Manyara and Haydom for having this meeting in Haydom. We thank Haydom Lutheran Hospital and the Global Health for bringing all the global audience to this place. We, as a region and as a ministry, we are expecting to receive the report and the deliberations from this meeting as soon as possible, so that we can make action and follow up on actions from this meeting.
Mabibi na mabwana, sasa kwa niaba ya Katibu Mkuu wa Wizara ya Afya, lakini kwa niaba ya Regional Administrative Secretary wa mkoa wa Manyara, nichukue fursa hii kufungua rasmi mkutano wetu wa pili wa wadau wa maendeleo ya afya, hususan kitita cha uzazi salama unaofanyika hapa Haydom. Naunga mkono kauli mbiu inayosema vifo vitokanavyo na uzazi na vifo vya watoto wachanga havikubaliki. Tuungane kwa pamoja kuvitokomeza. Asanteni sana.
So before Dr. Makwani reach the podium, I think that last paragraph we need all of us to raise. He says, we, on behalf of the Permanent Secretary, is now announcing this meeting, second meeting of Finance Stakeholders meeting, to be open. And then they join the slogan of, I think Beatrice said this in the morning, so all of us are going to do that. So Dr. Makwani will tena. So we follow Dr. Makwani with the slogan, before we are not wachanga, to lead us. Hello?
Yes. Vifo vya watoto wachanga, vifo vitokanavyo na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
Asante sana. Thank you so much, Dr. Makwani. And so these opening remarks are the two purposes. One, to give the message from the ministry. Second, to teach you Kiswahili. So how many of you have learned some Swahili words now? Okay, good. So ladies and gentlemen, I think we have been seated for almost 2 hours now. We take a health break, 5 to 7 minutes. You can use the washrooms, but there is also coffee stations out on that door. You can get some coffee, and then you can come back here and get seated in 7 minutes. Asante sana.
skills to use the data, the local available data for decision making, and make adjustments in their training at their local setting in the level, especially in the level. So that's the first component, but also we have some tools that enable these healthcare workers to be able to conduct those simulation-based training and put in the skills. And the aim here is to bridge the gap, because a lot of healthcare workers have the theoretical knowledge, but they don't have the clinical skills. And these emergencies, like the newborn resuscitation, the PPH, they don't occur that often, but when they occur, they usually fatal. So what we do is try to bridge that gap, that between the theory and the clinical skills. And how we do that is through individual and team scenario simulation training, so that the healthcare worker is equipped with the skills and also with the tools that can enable her to manage the clinical work. So that the first innovation is the training innovation. And then we have the clinical innovation, which support the healthcare workers to provide the care provision in the level. So the innovations include the fetal heart rate monitoring, but also the newborn heart rate meter, which is the new bit, which helps the midwife to immediately recognize if the baby is alive or dead, so that she can do immediate resuscitation that baby. And the third component is the continuous part improvement. And here we emphasize on the use of local data for local decision making. And Dr. Fong and Dr. Makwani emphasized on that, the collection of the data. So here the local champions or the local facilitators at the health facilities who are trained, they receive weekly feedback on the clinical data, but also on the training data. But also these training data are fed back to the health managers at the hospital, health managers at the regional level, but also at the district level, so that they can be made follow to the specific health facility who are doing the simulation, but also who are providing the clinical care. So the feedback loop is very important as far as quality improvement, and we emphasize on the use of the local data for local decision making. And we have seen that the quality of data, when the healthcare worker uses the data, even the quality of the data improves over time, because she knows that she's going to use that particular data for decision making subsequently. Another component is the sustainability. Here we emphasize on the mentorship and supportive solution and engaging the government at all levels. So from the health facility to the district to the regional, but also national, to make sure that there is local ownership of the intervention that are being implemented. So these are the main four components of SBDC, and they are equally important. So there's no, if you take one out, one puzzle, then the work will be incomplete. But also, how did we design SBDC? So we have a cascade of training where there was local simulation experts who trained the national facilitators in the first phase, and then the national facilitators trained the facility champions and the regional coordinators. And these facility champions are those people who are employed by the government, but they are selected in collaboration between SBDC team and the local authority and the healthcare workers who are the health facility. And then the facility champions, together with the national facilitators, will train all healthcare workers who are dealing with the mother and the newborn at the health facility. So our training, we don't take healthcare workers outside the site. It's on-site training. Why do we do that? Because we want all healthcare workers to get these skills, but also not to compromise the work that's also already taking place at the health facility. So this is how we use the cascade. In the second phase, we use almost the same, but the numbers are higher than what you have in the first phase. So the design was step-based, cluster randomized study design, where we have implementation in stages. So Manyara region was selected for this purpose as the first region, but then the rest of the regions were randomly selected using their simple random numbers, and then intervention took place. You can see we have relatively shorter baseline period compared to the intervention period. It's because there was a lot of pressure from the local authorities to the government to give the intervention to the needy community. So that's why you can see Shinyanga and Mwanza implemented almost around the same time. It was because that we are already seeing the results of the intervention. That's why we wanted to implement it quickly. So this was how we designed the intervention. So how do we scale up? So we use the sim begin method to train, and we start the scale up by training the local facility champions, use the sim begin program. And the facilitator became fundamental for shifting the culture from the blame and shame to the culture of quality improvement and learning. So initially there was a lot of blame and shame. When there was a maternal death, or there's a still death, or there's a newborn death, there was a lot of blames. But then we changed that culture. The facility champion changed that culture from the blame and shame to the culture of the quality improvement. And then this simulation training, we are coupled with debrief, effective debrief. I think most of you who passed through the site were able to see how they do the debrief. This is the long period where the healthcare workers will sit around and then discuss the case. And then this provides the psychological safety in the facilities, but also they make it makes the healthcare workers work as a team and not just as an individual. So they win as a team, they lose as a team. So that's why we use this model. And you can see the healthcare workers here who have just completed the simulation scenario and doing a training debrief. Some of my colleagues are telling me, you want to come to Python, we want to see the state-of-art simulation lab. So we don't have a state-of-art simulation lab. So these are our simulation labs in the health facilities. So this is an example of health center with the learning corner where you have placed a training equipment and healthcare workers can go there and train comfortably. So you don't need a big place or you don't need like a state-of-art lab. You just need to find a place where you can put your mannequins and let the healthcare workers train. And I hope you are able to see this in the site. That there is no like a special room. It's just a corner where you put the simulation equipment and then the healthcare workers will go and train. And you can see how big they are when they are training. Then this mannequin is, it has some sorts of a gaming nature where you can do a competition, like how quick are you going to make this simulator, cry, and so it becomes like a gaming kind of a play in those test facilities. Another important component which I mentioned in the 4 components of SaferBirths is the use of local data for local decision making. So this is an example of the health facilities who receive the data, the clinical data from their own data, and then which is analyzed, and now they're discussing what does it mean and what can they do subsequently. So this is very important for continuous quality improvement at their local health facilities. So in the first phase, we implemented in 30 hospitals in 5 regions, as I said, and approximately 300,000 dead mother pairs were observed in this phase. And in the second phase, we are implementing in 145 hospitals now because the CMOM sites are emerging and the demand is coming. So every CMOM site that's approved by the government is recruited or in SaferBirths in the 5 regions. And we expect to observe approximately 600,000 dead mother pairs. And as I said, this program is 10 PhD students, 7 Tanzanians. So this, we encourage evidence-based intervention. So that's why we are trying to generate evidence, but also building the local capacity. So some of these PhDs are government employees and some of them are private employees. But the aim is to make sure that there is low capacity for sustainability purpose. So what happened? So after implementing this program for about 3 years, we submitted our results to the New England Journal of Medicine, and they decided to publish. And I'm happy to present to you. I'm glad that 11 of the 12 authors are here. Dr. Makwani, before you go out, would you please stand up, the authors of this paper, so that you are recognized? Yeah, so it was a lot of work which took us about a year to analyze the data, and we have a marking force to respond. But this prestigious journal saw that it was important to publish this data. And so in February this year, this paper was published, and I think most of you have read it. And I will encourage you to take time to read the supplementary material if you want to understand better SBC. Because New England Journal of Medicine has a limitation of 2,700 words in the main paper. But we have a supplementary material which is 80 pages. So in case you have not read it, it's just at the bottom of the journal, and you can go in and look at on how in the details of what we did in the implementation of SBC. So these are the key findings. It's three most important numbers. There was 40% reduction in newborn mortality, newborn deaths, 7% reduction in maternal deaths, and 18% reduction in neonatal deaths. Continue to clap your hands. Yeah, so this is what we observed over time. So we started at around 8 deaths per 1,000. And the x-axis is the death per 1,000, and then the y-axis is the time. You can see as we were implementing in step-weighted manner. So these lines shows when the implementation started. So we started with Manyara, then Tabora, Geita, and ended up with Shinyanga and Mwanza. And this was the rate of mortality over time. But, a very big but, we didn't see a significant reduction in still deaths, with so many reasons. So some of the reasons include that most of our interventions focus on the newborn rather than labor management. So if you look at our interventions, it was mainly newborn resuscitation, and when you look at our data on training, most of the healthcare workers were training on newborn resuscitation and PPH management. So we think that maybe this is why we didn't see a significant reduction. So that's why in phase 2, which I'm going to show you later, we have put more focus on the labor management, obstructed labor, and the vacuum extraction in some of the regions, to make sure that these mothers or babies who are distressed are immediately attended, so that we don't reduce the number of fresh deaths. But also you can see, before the intervention, the reporting was low, but after the interventions, the reports went a little bit higher. So there was a culture of blame and shame, and this has been shown in the qualitative papers that we published. There was a culture of blame and shame in the hospital, so that people are not reporting the deaths that are occurring. So you find a woman coming to the hospital, and when she has a fresh stillbirth, the next day there will be no report related to the death. And it was fear of being blamed and being... So after implementation of STBC, we tried to change that particular culture of blame and shame, and then we saw some significant improvement in the reporting of the outcome. So that's hypothesis. It's not like it must be happening, but that's what we hypothesize. So we also saw a significant reduction in maternal death from 260 to almost 70 deaths per 100,000 births, which was a very significant reduction. So we are asked, was this homogeneous across the regions? The answer is no. So there was a lot of variations in the regions. You can see there was about 80% reduction in Manyara, about 7%, no reduction in Tabora. So we didn't see a significant reduction in maternal deaths in Tabora, with so many reasons. We have some point about they can explain later why we see significant reduction in maternal death. But some other regions have very high reduction. In one it was 85% reduction. So there was a lot of regional variation depending on how often they train and what type of scenario they are training on, but also the system issues at the health facility that they are working on. Another that we've been, I've done several presentations to different colleagues. We've been asked about the secret episode. Some people wanted to show that was this the result of intervention or that was already a trend in mortality. So we conducted so many analyses and performed the main analysis we did it without secular trend. And we provide a lengthy explanation in the supplementary appendix. So if you get time to read the appendix on page 12, it was impossible to disentangle secular trend and intervention effect in the given design. So the design did not allow us to provide conduct secular trend analysis. But to confirm this, we collected data from similar sites in the same regions, and we tried to see if there was any trend in reduction in maternal mortality. And we didn't find any trend in reduction. So this was newborn mortality, this was maternal mortality, and this was pregnancy death. So there was no trend in the reduction of this death in the similar regions, in the similar hospitals, in the same regions. So we postulate that probably this intervention had effect in the hospital that we saw the reduction in the mortality. But we conducted several sensitivity analysis. That's why, for those who are interested, I encourage you to go and read the supplementary material. So there's a lot of numbers that you can see, but I'll pick it too. So even with secular trend, the reduction in maternal mortality was by 50%, even with the secular trend. But without secular trend, it is 75 mortality. So these numbers, you just take 1 minus the number, then you get the reduction. So here it will be 50%, almost 6%, and here it will be 75% reduction. So we believe that these analyses have been conducted in several sensitivity analysis have been conducted, which confirms that the reduction may be the reduction, the results of the intervention that we implemented. Yesterday we conducted a seminar, PhD seminar, and I want to briefly present to you some of the key findings that have been presented, and this is unpacking the whole puzzle. There's a reduction, but what happened in the behind the scene? So we have seen one of the papers, about 15 papers have been published, and some of them are under review. And there was a reduction in maternal deaths, in significant associated with the frequency of team simulation training. So we have found that the more the healthcare workers train, the more they are likely to reduce their maternal mortality. So that paper is under review, and it will be published very soon. Another paper indicates that documentation of PPH among the women with severe outcomes improved significantly during the study period. So there's improvement in documentation, which is also part of the respective maternity care, because if you don't document, then it means that something that did not happen. But still, there's a huge gap in providers' registration and reporting of PPH, which are working on in the second phase. And we use the mortality life simulator, and the mean score among the healthcare workers immediately after the training was 93%. And 1 year later, it was thought to be 82%. It's a drop of 10%, but several literature show that in most of the training, after 6 months, the drop will be by more than 30%. So we believe that the low dose high frequency that is taking place in the health facilities is enabling the healthcare workers to retain the skills that they are training on. But also in these hospitals, there is staff shifting from labor ward to antenatal ward to the surgical ward to the other ward. So about at the end of the SPBC1, about 40% of the staff have moved to the other departments, and then about 40% were new. But we also found that even those who are not trained at the beginning, they have the skills. So there is a peer-to-peer kind of skills shifting among the healthcare workers, which was significant. The average one stick training was conducted with 80% well done. So the skills retention was very good. But frequent training was reported to increase the work burden, but still highly accepted. So they report that yes, but training increases some sort of burden, but still they accepted training because the training improved their skills. The clinical burden per healthcare worker did not affect the frequency of training, and active use of only hospital clinical and training data facilitated ongoing training and continuous quality improvement. So the use of data, one of the papers we published in that the use of data for quality improvement encouraged them to train more, but also improve their quality improvement in their facilities. So one qualitative paper, that's the under review, showed that relevance, quality, and quality of training, establishing the culture of ongoing learning, were perceived as the facilitators for acceptability, motivation, and the success. And some other details which I think you can find in those published papers. But we have also conducted cost-effectiveness analysis of the bundle, of the whole bundle, and we have found that if you combine the number of lives saved as a result of the intervention, about 600 mothers and 600 newborns and 400 mothers have been saved as a result of this intervention. And the cost for implementing this program was around $4.5 million US. So the cost per life saved was around $5,000 US. And cost per life year gained was $80 US, which was far below the global standard. And the cost per daily and disability life years abated was 144 USD, and the best benefit cost ratio was 36. So as per WHO, SBC was highly cost effective, and the cost per daily abated was less than gross domestic product per capita. So the paper is under review in the public library of science. We hope to be published very soon. So in summary, what did we learn under SBC 1? National and local ownership. So you've heard Dr. Faume and Dr. Makwan that they are engaged right from the beginning. So national and local ownership from the very beginning in the planning through implementation is critical for successful of this intervention. But we have the engine of change. So we call the local facilitators the driver of the in-situ simulation training as the engine of the change. Because you need to have somebody specifically looking at that intervention in the health facilities, especially to encourage the healthcare workers to train. So training at the health facilities with local champions is very critical in these interventions. Data driven for continuous quality improvement is also should be critical and very important. Without data, then you don't have the right to say. And healthcare workers formally didn't use their data, so they have no incentive of even collecting the data accurately. So data-driven for continuous improvement has been shown to be important. Mentorship is very important. So SPBC team, but also the local authorities, the health management team at the regional and the council level was very, very important for sustainability of this program. But also we need to establish a system for equipment maintenance and the processing. So we have the training tools, the clinical tools. It's important to engage the biomedical engineering of the local facilities so that they can be able to troubleshoot in case there is issues that they may be raising. So these are the if you forget everything today, you can take these 5 points as the take-home message. So what did we learn from SPBC 1 and took them to SPBC 2? There was a need for continuum of care, especially for the smallest newborn. So we have introduced the KMC simulation training in the SPBC 2, but also the other leading cause of maternal and prenatal death, including preeclampsia, prolonged obstetric labor, have been included in the bundle in the second phase. But also we are addressing intrapartum stillbirths, where we have started in selected facilities. This is not a new intervention, but it's an intervention that has been forgotten, And Dr. Fale, you can attest to this, that safe vacuum is not practiced in most of the facilities. So we started it in the 5 best facilities in Manyara to train on the safe vacuum extraction so that the healthcare workers can be confident, especially for the second stage C-section, because there's one health facility in Manyara which has C-section of about 30%, and that's very high. And most of this C-section can be avoided by simple intervention, like it's not simple, but an intervention like vacuum extraction. So you can avoid a second C-section to the mother by doing a vacuum extraction. So we are working on this program in project to make sure that we reduce first the stillbirths because they are still high, but also the mothers to avoid the C-section which have a lot of complications. But also we have included more training on the scene begin, the local facility champions, because the competence of the champion is very critical for successful intervention. So next step, SPBC scale up in 42 regions, bundling the bundle. So we are working with at the beginning fund, and we hope this will materialize with Next 360, Dr. Masanja said. And we believe that Nesti works best when SPBC comes first. Isn't it true? Yes. It's true. So Nesti will work best if SPBC comes first because we use the budget to go there. So we are working on that, and we hope that program will start being implemented in 10 selected sites in the 12 regions. But internationally, as the Trinity has said, we are working with the NCA and China, finding some states in Bono and Gombe to implement the SPBC. In other countries, they have shown some interest. Hello?
Yes. Vifo vya watoto wachanga, vifo vitokana na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
Another one? Hello?
Yes. Vifo vya watoto wachanga, vifo vitokana na uzazi, havikubaliki. Tuungane kwa pamoja kuvitokomeza.
Thank you so much for listening.
Let us give a loud applause to the presentation that was SPBC done, the results and the cost effectiveness shared. We also have the budget here, so during lunchtime, you can come and have a presentation. I'm going to welcome the next presenter, who is Dr. Robert Mishiro. He is a pediatrician and head of the unit research unit at the National Hospital. He's also a lecturer at Nairobi University and an SPBC co-investigator. Let us give an applause to Dr. Robert as he comes forward.
Thank you very much. My pleasure to be in front of you, and so I'm going to take you quickly to the results of the phase 2 of the implementation. And in this phase, we are into 142 facilities in the same region that we're implementing phase 1. And obviously, because we have already had our presence in the first, in the 5 regions for the first 3 years. So, because we had our presence in the same regions for the first 3 years, we know that there is some benefit that we're carrying forward, and this includes digitalization of the low-dose high-frequency CQI, both the regional and the district level. But also, because we have been collecting prospective data for the last 3 years, we know that at least our baseline is right now for the initial 30 facilities is a little bit more accurate compared to the facilities that will be joining in the phase 2. But also, we know that the addition, the many sites that were added in phase 2, these are smaller sites, health centers. Remember, during the phase, we selected sites with high burden of maternal mortality and newborn mortality, but also sites with high rates of deliveries. So the additional sites in this phase, they are smaller, less deliveries, but also they are many sites. But also, we expect to see a lot of variations as we saw in the phase 1. And this time, our implementation period is shorter compared to phase 1. So some of the preliminary output results that we want to show. So the first row, you can see the number of staffs in the labor ward and across all the sites. The deliveries from January 2023 to May 2024, almost 378 deliveries across all sites. You can see also the number of maternal deaths across all sites. In the highlighted row in yellow, you can see the rate of maternal death per 100,000. Overall 64, but you have much less in the health center. HC represents the health center, and BH is the district hospital, and RRH is the regional referrals. So as Dr. Faouk was saying earlier, the health center and the district hospital represent the primary health care. You can see actually a lot of deliveries happening in the area. But also the health center, you have less burden of deaths because, as you expect, they tend to refer to the island facilities. But also, if you look at the rate of first death and 24 hours newborn death, the same, you have a little bit more burden in the island facilities. So also, this slide shows the training data that we've been collecting from June 2024 to June 2025. For those who visited the sites together with us day before yesterday and yesterday, you can relate to this. More or less similar number of deliveries. We have recorded almost 950,000 individual training data across all the sites. And if you do the calculation based on the number of staff, then the skills training per healthcare worker per week, each individual healthcare provider trains individually at least 5 times a week. That was one of the, I think that was one of the questions that popped up yesterday, the day before, like how much training is going on in these facilities for the individual training. And for the team training, we capture this data using the LIFT platform, and we have recorded almost 26,000 team trainings for the past 13 months. And on average, each facility conducts 3 team trainings per month. Again, this was another question that was asked yesterday. And here you can see that in regional referral hospital where you have more healthcare providers, they tend to conduct more team simulation because it's much more easier compared to health center where you have few healthcare providers, and at least they will maybe conduct team simulation once a month. And the average number of healthcare provider per each team scenario is around 6 healthcare providers. This is a pie chart that shows the type of team simulations that are conducted, and we have more of PPH scenario that have been conducted by healthcare providers, almost 40%, followed by the helping babies breathe scenario at 25%, advanced around 15%, fetal monitoring around 12%, and kangaroo under care around 10%. all this information captured by the platform. And now the preliminary outcome results. Remember, we did not conduct any statistical analysis. I'm just going to show you trends over time. And these plots on the vertical axis represents the mortality rate per 1,000 for this case of intrapartum stillbirth. And the horizontal axis represents the time in months. And then the green dotted line, the green dotted vertical line represents the time when we started collecting data prospectively. And the blue vertical line represents the time when we started the implementation. So this line represents the trend of fresh stillbirth rates across the new sites, old sites, and combined sites. We see slight increase of rate of stillbirth for the new sites, much more maintaining the rates of stillbirth on the old sites, but in the combined plots you can see that there isn't any difference that is evident in this plot. For the 24 hours newborn deaths, similarly for the new sites, slight increase after the start of prospective data collection. The old sites that maintain the same rates, more or less, from the previous phase 1, and the combination is more or less no significant change seen there. For the maternal deaths, again, we see a lot of variation, but for the new sites, slightly decrease, you can see, but the old sites have managed also to maintain more or less the same. And the combined plots slightly decreased, but if you go further to look for the maternal death to differentiate between the sites that were present in phase 1, you can see for the health centers, they actually maintained the rate of maternal death less than 60% per 100,000 that was reported in the SaferBirths, Amanda just explained. Similarly, the district hospital has also been able to maintain that number below 60 per 100,000. And referral hospital, likewise, you can actually see a trend that is continuously going down. But for the new sites, for the maternal mortality, this is the overall combined plots, and you can see as you can say there is a reduction for the time that we started implementation. However, in Mwanza and Shinyanga region, you can see that before the baseline of prospective data collection, there are several months, 6 to 7 months, that they actually reported no deaths. But after starting collecting data prospectively, then you see numbers are going up. And for Tabora, you can clearly see that there is a reduction of mortality from the time we started the implementation. So this is a combined plot for all the sites in SBC2. And here you can see that for the first graph of maternal mortality, a little bit of variation, but you can see for the old sites in blue, the new sites in red, more or less all the new sites started with the rate of baseline rate of mortality lower than the old sites. As I said before, the old sites were selected based on the high burden and high rate of mortality. But also for the 24 hours mortality, you see that at the beginning, the gap between the old site and the new site is wider. But as the implementation continues, we think that the old sites improve, and probably the new sites improve on documentation, and the gap gets smaller, but overall a little bit of reduction. And for the fresh stillbirth, as Ben explained, you don't see that change at all. And this is probably because we have only one intervention, the fetal heart rate monitor, that addresses fellow fresh students. Now, we are going to analyze this data at the end of this year, and several things that we will have to consider, including the huge variation that I just showed you here. And it's going to be definitely a very complex analysis. And also, in phase 2, our data collection is more or less like retrospective data collection, I would say, because in phase 1, we had data collectors on site. But right now, we don't have data collectors on site. Rather, they go around the sites and collect data prospectively. So that makes it difficult to correct some documentation issues if they are there. So we expect a lot of some missing information. But we're going to conduct a mixed effects distribution model, and we anticipate, as I say, varying intervention effects by region and the facility level. And we also anticipate time varying intervention effects, because it may start now, but it might take a bit of time for the actual intervention to take effect. And also, we expect to conduct separate analysis for the old site and the new sites, as well as at the facility level and regional level. Thank you very much. And now I'd like to welcome Dr. Esto, if he wants to, or if you want to add anything regarding the phase 2 documentation.
Thank you. Thank you. Thank you. Well, it's not about the shoes that you wear, but the steps that you make is what counts. It is not about the shoes that you wear, but the steps that you make are what counts. So I was trying to go through the number together with Robert, and what is really interesting that I found is that in phase 1 they said we had 30 facilities, and in phase 2 we had 142 facilities. And the reported data with phase 1 covers 3 years, and in phase 2 covers about 1.5 years. Okay? So it's like phase 2 in terms of time is 50% of phase 1. And I was also looking at the number of training, because now we are aiming at the skills, and at the end of this information I'll also give a token for this. So in phase 1, individual training was about 126,000, and in phase 2 it's about 950,000. So in phase 2 it's about 8 times more than in phase 1. For group training, in phase 1 we had about 6,000, and in phase 2 we have about 100,000, which is about 16 times in phase 2 compared to phase 1, which shows that as we scale up, the effects multiply. So I'm sure that practice makes perfect. The more there is practice, the more perfect it will be. That's why I'm saying that it's not about the shoes that you wear. The steps that you make is what counts. It's not about helping the man, but the slogan, the death of the women and newborn are not acceptable. Thank you.
someone was trying to. I think someone tried to escape the podium. There was no transition. Let us put together our hands for Robert and the team for the transition. Asante sana. So next, we are going to be having a plenary that we also allow for the audience to ask some questions. But before the audience engages, we'll have some panelists. Dr. Bundala, I'm not sure where the bosses are, because they, yeah, no. So I'm asking my colleagues to bring the chairs on stage. Let us have the chairs for the panelists. Just the number 20. People come to from number, so just a matter of be later than. So, and little see if you can help me see Dr. Makwani is around and Dr. Paume. Here. So the Makwani is here. Dr. Paume. So I'll go on stage because we heard from the investigation team. We heard from the investigation team on what been achieved. But then we have the government, the real owners of business who have invested in SPDC and who can tell us exactly what is happening to the lives of people and into the health systems of Tanzania as a result of SPDC. And then we can ask practical questions which do not look at the study design, but they look at the changes made. So may I welcome on stage the following panelists. We have Dr. Ahmed Makwani, Director of RMNSA from the Ministry of Health. Karibu. You take the middle seat. Makofi Atoshi. Dr. Paume Rashid. You take the right side of Dr. Makwani. That's it. Right. Karibu. We have Cecilia Murema from Mwanza, representing the General Health Management Team. And we have Dr. Pascal Mdole from Madam Lutheran Hospital, representing the partners. Asante. So, ladies and gentlemen, I will take I'll have some questions for the panelists. One question for panelists, for them to sum it up and give the contextual information around SPDC before we can engage them with the questions for them. So I'll start with the host, Dr. Pascal Mdole. Okay, we have a microphone. Yes, let me start with Dr. Pascal Mdole. So we heard from the guest of honor that Norwegians, this is their home at the end of the hospital. They don't just come for visits, they come for work. You guys have been one of the institutions that has demonstrated collaborative projects in research that have impacted the lives of people and have informed the policies of Tanzania. Can you tell us how IDOM as an institution and Tanzania as a country is benefiting from the collaborative work that you are doing with the partners, not only under SPDC, any other work, And do you have specific examples of how Tanzania or the country and the institutions like IDOM can benefit from this kind of arrangement?
Thank you very much. We are very happy to be in this institution because we have been working with the region for many, many years. The hospital started in 1955. It was initiated by Norwegian Lutheran missionaries who came here and started this hospital. And by that time, this area was the home of wildlife or wild animals. So by coming there, they established the health services here, and people started moving from all parts of the country and the world coming to Haidom. And today, Haidom is a global village. Everyone is at Haidom from all over the world. So this is a big achievement. But since 2009, when we started officially the research activities at Haidom, we had a very good and huge investment from our collaborators. We have been collaborating with many international and national institutes in research. And this has contributed very much to the growth of this hospital, to be known in the country but globally. Now, if you talk about Haidom, it's very well known globally and in the country because of what we have been doing. And with the collaboration with our partners, we have managed to produce high quality evidence in medicine that has contributed very much to the international treatment guidelines that are used globally. If you go to look on the guideline for newborn resuscitation, there is a lot of citation from Haidom work. So Haidom has contributed to the international guidelines that are used globally. Not only that, but we have also contributed to the development in continuous quality improvement initiatives globally. When you talk about primary health care services, Haidom has contributed very much. The research that has been conducted at Haidom has contributed very much. Not only that, but today, all of you have traveled all over the world coming to Haidom. Very rural, remote area, but you have managed to bear with all difficulties of traveling coming to Haidom. This has a huge impact to the community around here. The research that is being done at Haidom has contributed very much to the economy of the people around here. Today, people have built a guest house in town, in hotels, they are running business because of the hospital. The hospital has grown so much that has impacted the lives of people around here. A lot of people have benefited by getting jobs from here. For example, the SaferBirths Bank of Care, one research, has employed more than 150 young men. So they got employment because of what we are doing at Haidom. Not only that, but the quality improvement at the hospital. The services at the hospital has improved very much because of the work that we are doing as a research. Retention in human resource. Today at Haidom, we have a high qualified personnel in health that are working at Haidom, PhD holders, specialists. They are working at Haidom because of what we are doing, because it's not only giving service, but also educating others. So we are very much proud of what is happening, and we hope we continue to benefit from our collaboration.
Thank you so much. I just want to confirm that the beneficiaries of the jobs at Haidom is both young men and women. So just using men to represent both. So thank you, Dr. Ndoe, the Executive Director of the hospital, for the historical impact of the work that we are doing at Haidom. Now we have, when Dr. Ndoe was talking this morning, he talked about the importance of investing in primary health care. And now we have a person from the regional health management team in Mwanza, who, as a member of the regional health management team, and she being a technical leader of maternity programs in our region, including SBDC. I would like to hear from you, Sister Cecilia. What do you consider factors that facilitated your team and your region for easy take-up of the interventions, the bundle, at regional level, council level, facility level, to impact the lives of the beneficiaries? Karibu.
Thank you very much. In one direction, we have in phase 1, we implemented this facility. Then we scaled up into 34 facilities in phase 2. And in implementing the intervention of SPCC, we are using the regional and district approach. We are the plan who select and who supervises the intervention. So we started selecting the facility ourselves, facility which we implement the SPCC. We selected the 6 facilities in phase 1, and then in scaling up, we selected the 32 facilities which implemented the deployment. And in these facilities, we also involved in selecting the trainers of trainees within the facility to implement the SPCC project. So we selected the healthcare providers who will train others in intervention which is implemented. And from the TOTs, these TOTs are the ones who are trained the champions who are selected by the region and district. So we are involved in selection of TOTs and selection of champions within the facilities. And these TOTs and champions are the ones who train healthcare facility within the facility. So we are letting we did the interventions, and we make sure the healthcare providers are providing the quality services through these interventions. And in monthly basis, we are doing the job training and mentorship, and we are the supervisors, district and regional teams as the supervisors of this mentorship. We are doing the on-site and on-job training mentorship using these TOTs, regional TOTs and champions. And to join hands with SPCCs and other projects as a region, we advocate the no blame in reviewing perinatal maternal death. We advocate the no blame, no shame approach, so that every facility will review their perinatal and maternal death without shaming and blaming and measuring. And we are advocating to report every maternal and perinatal death occurring in the facility. And also, we have forum in the facility. We have a routine data discussion, perinatal interpattern services discussion. The data which is receiving back from the SPCC. In the facility, we discuss them in the routine, in the weekly basis. And also in the region, we discuss the data in a monthly basis. We discuss the perinatal and maternal death in not monthly basis, in a weekly basis. We buy in the approach of Ministry of Health of doing Zoom review meeting in monthly basis in every region. So once a region buy in that approach, we are discussing the maternal and perinatal death Zoom meeting, and we are supporting the Zoom link by SPCC. So every week we are discussing the perinatal and the maternal death occurring in the facility, involving the specialist as the moderator, and regional medical officer is a chairperson, and regional reproductive and child health coordinator is the coordinator, and RIO is the secretary in this meeting. And also, joining hand with this project, we also have forums like WhatsApp forums discussing the latest cases within the region. And this forum, we said maternal and perinatal death is a word, and everybody should fight these words. So we involve all RHMPs and CHMPs in making sure that they are watching the emergency cases in the facility. So what we done is to have something called Lindo, that is like dog watching. Every RHMT as a lead and CHMT have a timetable. In every week they have to supervise and stop checking all emergencies posted in the group and organizes the resources like blood transfusion or organize teams to respond to the emergency, and all can consult the specialists to respond to the emergency. So in every week we have one CHMT and one RHMT who is spot checking in the group the emergencies which is posted in the group and respond to the help them to organize to respond to the emergency. And also we had scorecard of maternal and perinatal and scorecard of ambulance, function ambulances. We find that there is a delay of referral due to the ambulance that have not fuel. So we make sure the ambulances in the districts have fuels and function. So we have a scorecard of reporting the daily basis in maternal and perinatal death occurred in the facilities and posted in the group. And we have also scorecard of function ambulances with full of fuel from 50 liters in every day. So that is a process of the regional supporting this project to make sure that we accelerate the maternal and perinatal death. Thank you.
Asante sana. I'll come back to you. At some point, remember to Makoki. It's always good to hear from the horse's mouth and the actual practical things that they do. So we'll come back to the audience for some questions. I know some people already raising their hands. Let us go to the President's office now, who are in charge of all the permanent care. And Dr. Paume, what Dr. Cecilia has been explaining, it all can't happen if it does not have blessings of the President's office to be implemented in such a permanent care facilities from the district down to the dispensary level. So we understand that the government has already been actively taking part of investigations in DC, as you said, in the morning. Now, can you share with us where we are now in terms of making sure we take up most of these interventions for them to be scaled up? Because 142, and it doesn't have so many facilities, over 8,000. So 142 is not enough, but it's a good sample for us to learn from and scale up to the remaining parts of the country.
Thank you very much, Moderator. First council. So, we, as Tanzanians, and at a strategic level within the President's Office Regional Social Organizations, we have the enabling environment in collaborations with the Ministry of Health, availability of well-prepared design policy guidelines in the area of reproductive maternal newborn children. To us, that is an opportunity, coupled with the well-stipulated roles and functions of regional health management systems. I'm not talking about the function of a member of regional health management team, but we're talking about the systems. Within a system, we have a subsystem for reproductive maternal newborn children at the regional level, at the council level, and the country. Even the component of planning these planning guidelines are decentralized at the facility level. So when you go to the dispensary, the lowest level, they are conducting planning on their own with the guidance of the available CHMT, council management teams, adhering to the guidelines, planning and reporting guidelines, but also adhering to the national strategic document, right? Document, as I said, guideline in relation to reproductive maternal children. So, understanding and witnessing the data from the research from the SBDC is obvious, and of implementation of SBDC and supervising alignment because whatever has been implemented, as I said in the morning, is a pure lie in collaboration with the other ministers, Minister of Faith, who are supervising this research projects. Whatever is being implemented aligns with the national guidelines. So the good thing is that we can stand anywhere in the world and saying that the findings, whatever has been implemented, is true reflection of our priorities and priority guidelines. That is at the strategic level. But the other thing is, when you're talking about the achievements that are already there through the research projects, taking them to sustain in the future. Now, in the future, there are a lot of things already done in terms of, for example, capacity building. And the good thing is, with the capacity building, it's like other traditional approaches of the capacity building. This was hands-on capacity building. Because I've been visiting the facilities, some of the previous known capacity building sessions were just sessions calling people at the headquarters of the country, Dar es Salaam, or if it is Nigeria, Abuja, calling them at the center and teaching them. So this is like that. There are people are being trained and so on with training tools that really are coupled with the advanced technologies. So that's really what I see it as a very important approach towards achievement, but towards building capacity on our side as a pure line and putting like the benchmarking for sustainability. And what we have started so far, together with cooperation with the Minister of Forest, is, for example, Mama Natalia, those Moyos, but we have started negotiating, not negotiating, already talking within the government, of the government agencies that deals with the procurement, storage, distribution. Now there is an added law of manufacturing. It's MSD, Medical Storage Department. So it's the government agency and the Minister of Work that with the good achievement that we have seen, the government has seen the importance of making sure that these tools, learning tools, are available within the government procurement, storage, and distribution network. And the facilities can order these equipment through their budgets, whether you can budget from the central government or the locally collected revenues. So that's what creates important aspect of sustainability. And the project has created a pool of already staff, as you can see in those facilities in phase 1, only phase 2. So these are like the master trainers. So we are going to use them to train other facilities, because we are going to procure equipment, training them on all those interventions to make sure that we scale up and we make use of the good findings that we see now. But in terms of financial sustainability as well, we are the POLAs. One of our roles is supporting or coordination of planning and budgeting of the local government authorities. And during the scrutinization or assessment of the annual plan in the budget, before this plan in the budget endorsed by the Parliament of the United Republic of Tanzania, there should be scrutinized by the relevant ministries. For all of the pure line facilities, dispensary centers, district hospitals, my department under the Minister of President's Office, we have to scrutinize them to see if these priorities that we are talking, including our research priorities, are being captured and well budgeted for. But also continue partnership. Because one of our roles is encouraging partnership with different IPs and state actors, faith-based organizations. Thank you very much, Bishop, Assistant Bishop. So we will continue not working in isolation in silos. We need continued support with different partners. Currently, we have started engaging the beginning funds with and other funding modalities for intentions, and these interventions under SBDC are some of the interventions that are also captured in the current current initiatives. But the use of data is very important. And the role of PLI now, we have seen the major challenge. I don't know if this is also occurs in other countries. We invited guests, maybe we'll contribute later. But we have a bank of knowledges, research findings in our libraries. But the problem is how do we put those relevant findings into practice, like what has been done under SPCC. So the PLI has mandate of implementation coordinations. So in support with the UNICEF, we have already developed the evidence-informed implementation roadmap. It is costed. So can I call upon also, I will share with you partners to see how can, it's only costed. We don't have funding yet to implement these interventions. But this is very important. It looks into factors that can facilitate now putting into actions of very important findings that are supported by data, like what has been done under SPCC. So can the interventions be implemented in C? Are there capacity issues or opportunity issues not yet explored? But the other area is really the use of data. That's the area that we are looking for. Having the dashboard and PLI digital platform, where the so-called got on this, we are enhancing interoperability of these dashboards to see how can we, when we are the PLIs, communicate directly on site staff and sharing the progress on daily basis. Finally, I know the time is not on my side and people want to contribute, but really, I comment, or I really appreciate the ongoing, the political support. That's very important. Vice President herself, as I said in the morning, the peace in the country. So for those who are not coming outside of Tanzania, please, do that. This is a conducive environment to continue working with the Tanzania. So please, welcome, working with the government of Tanzania, working with the PLI. Thank you very much.
So, Dr. Mfaume, I think, as he had just introduced, they oversee the quality of health services and prevalent care, but following the national guidelines and the protocol. And then who develops the guidelines? The Minister of Health. Now, there will be no better person to talk about how the country, for example, now trying to take the lessons from interventions or studies like SBC, make sure that they are reflected into the national guidelines and the protocols, and to be able to help the improvement of the innovations as well as the quality of care at the facility level. Karibu Dr. Mwakwani. Of course, the champion of FBSL as well.
Good afternoon again. Yeah, it is true that SBCC is one of the interventions that the government has embraced in its policy documents. And we have worked hand in hand with the newborn essential solutions and technology to make sure instead of having duplicated efforts, we combine the two so that we can work together. We think they were very often IDO and Fakada Institute and the other interventions were able to come up with one roadmap so that it can be easily assimilated. But first of all, let me examine the policy position. What the government has done. First, we look globally. Globally, this year, I think the WHO ratified a special day to commemorate premature baby. And that, I think, to be 17th November. The premature baby age was being commemorated in, I think, less than 100 countries globally. And our colleagues, Moreland Foundation, I'm not sure if they understand here, they wrote to us if we can start that motion. And we started the motion. We thought, we started the motion and we thought it is going to drag over years so that the partner states they can agree. We got support, I would say, almost all African countries. Thanks Nigeria, thanks Kenya, thanks Lesotho, thank you everyone from Uganda, because we were sitting, I would say, after every week, on the evening, very late hours, yet you could see various countries. Thanks Norway for the northern countries, they were one of the people who co-hosted our need for having a special day for premature death until it got ratified. So I would say that is the first and the most important landmark globally to say Tanzania with the rest of countries globally agree to have a special day to commemorate premature babies. And that day is not just commemorating, but it calls for putting resources to ensure the survival of premature and newborn as well. So that is one of the areas where we'll be able to take the interventions, innovations further globally. And I would say we have been very infectious in that sense to manage to convince every country that this is an important area. Secondly, globally, we informed, I think it was in 2009 or 2010, that helping baby to breathe is an answer towards the survival of newborns. Dr. Georgina is there, I think, was a leading author for that publication. I just want to show you vivid examples how Tanzania is able to take various innovations so that we can bring changes towards the community. And they are focusing those innovations that reiterates the need of improving maternal and newborn and child health. In 2018, we started WhatsApp groups. We started the WhatsApp groups with our experts from obstetrician gynecologists, pediatricians, anesthesiologists, midwives, mentioned cross-cutting providers, whereby we were able to take specialized care to the remotest point of the country, whereby there is a woman who is lying beside the grave, ready to die. And then these people, they work with the grassroots level to reinstate to come back to the world. We served, we published their paper, which shows that if you could take this innovation to the remotest point, you can save life. And I remember, we have reported 584 cases which were managed in a span of 1 year from 2018 to 2019. And those were critically ill women. Only 4.6% succumbed to death out of those 586 cases. So for us, we are taking innovations bits by bits. Then we got SPCC bundle. And as I have said, we saw the results from SPCC. Myself, I came to learn SPCC here in Haida. And we visited some facilities including Haida, including the Bull District Council Hospital. We saw the Bull District Council Hospital. I think initially it was not part in the project, But because because of the results they saw from Cairo, they decided to start their newborn care unit. And they gave us nice stories that we learned from Cairo, and we decided to replicate. There were good stories which showed us that if this approach is replicated throughout the country, we are likely to get the results. And from there, we embraced it. And that's why I asked Dr. Felix Budara if he could stay. Dr. Felix Budara is an assistant director responsible for newborn and child health care. Actually, I told him, Dr. Budara, you need to enroll for PhD. Initially, he was saying, PhD? I said, because I wanted to have access how best we can scale innovations throughout the country. Finally, he agreed, and he's one of the students under this program from the SBCC Bando, which is a program run by IDOM and collaborators like University of Dar es Salaam and the other collaborators. The purpose was, if these innovations are working very well, we need to have somebody who takes them very strategically to make sure that they can go throughout the country. And that is the role and the responsibility of Dr. Tal. And for us, we saw that very, very important investment. Because if you don't make a champion, I can tell you will not get results. But also, we worked with our colleagues. We had a representative from every industry who was part and parcel for the development of the Vision 2050. And that was not anybody else but Dr. Uturi Kapologwe, who is now serving as the director of Exide. And every time I would go to Dr. Uturi, please put a statement there on newborn investment. Fortunately, at the end of the day, we have a statement. You know, that is a country vision. You just need a sentence that will underrate the need for you to scale what you design. We have a statement there. A statement mentioning a newborn. So for us, that is a milestone in policy. And then we will be working with our colleagues, making sure that this agenda can go to DPGF. I think you got some slots sometimes getting into the DPGF so that others can understand it as well. And we scale it further. It is going to be part of the health sector strategic plan. And for us, one plan is two. We took HPV, helping baby to breathe, and now we are going to add another milestone, which is SBC. So I would say for us, we'll be taking various interventions. And my colleague here mentioned about visual maternal death review. We have reviewed so many cases. Now I would say we have reviewed so many cases of maternal and neonatal deaths. Actually, we do have a manuscript in PLOS, which is partially accepted. We are addressing issues which have been raised in that day. And we have loaded it to +1. And we are expecting possibly in 6 months to come, maybe that manuscript will be a full paper to be shared to the peers. So in a nutshell, I would say, we as policymakers, strategy makers, we as the guideline makers, we have embraced the SBCC model. And as we buy equipment, for example, one of the requirements for the neonatal care unit is having stations where providers can sharpen their skills. So for every ward we are opening, we emphasize the importance of having a station where healthcare providers, from time to time, they can go and sharpen their skills. So we take the innovations and we will continue if the government is getting convinced with innovations, we will take them. And we have managed to sell this SBCC to the high office as well. And actually now we are not moving on our own speed. We are moving with the speed of the head of the state. So how much do you want us to take it in the policy? It is high up in the policy. I submit to you.
I'm trying to think, why did we start with this plenary in the morning? Maybe we could have talked the whole day. So thank you so much. That's very informative. In fact, I think in like 15 minutes, people have known what's happening in Tanzania. Even those colleagues from Nigeria can now make a presentation at WHO of the health system and the maternal newborn health programs in Tanzania. So just to reiterate what Dr. Mabwana has said, we are now in Tanzania around this time. It is due to develop a number of strategic plans, including the Sector Strategic Plan 6 and the One Plan 4. And this sentence has come at the very right time. And the people who are involved, we are here, so under his leadership. So looking forward to incorporating those things into the strategic plans. Colleagues, I know we're behind time, but I can't deny the opportunity for the audience to ask some questions, because these people, they are very rare to get. Now, let me welcome 3 comments or questions first, and then we'll see if we can take another round. Yes, Nancy, did you have a question? I think you are raising up your hand. No? Okay, please. Now, Mr. Here, microphone.
I want to thank the panelists for the nice presentation and giving us a therapy. So thank you. My question goes to the Dr. Zaya Dennis and the Country National Mortality Reduction Initiative. So, I mean, so we are excited to be here, but something struck me when the you were talking, you said financial sustainability is not important. I also understand the fact that the other getting the people spiking, all of that are important. Well, I'm super, I want to understand the funding of all of this. I know there was a grant from, I think it's engaged or we funded, but the country, in terms of now scaling up, how are you able to fund this? And then number 2 is, because the country also operates the free health services and have some DRF, it's also being operated. What is the role of insurance in all of this? And then just to make a quick comment around the fact that even though there are researches, but they are not being done. So most of the problem the research is that researches are usually not done for the priorities of the government. So when they are done with the government priorities, then they are very useful for the government to implement. So researchers should pay attention to government priorities. Like you see all of that has been done on SBPC now, is what we are adopting and scaling up. So what are the researches that you do that is outside the government policy will never get to be utilized? So that's my own quick comment about it. Thank you.
Thank you. Any other question or comments? Do we have any question? Yes, Grace. Do we have a colleague there?
Thank you. My name is Grace Hall from Jerry. So I would like to commend the Minister of Health and Iraq for uptaking the SBC intervention. Mine is just a comment. I would like to just talk about the lessons the SBBC QI M&E framework has really helped shape what we're seeing today. So we are very open, with open arms, to share the quality improvement framework, especially the M&E process indicators. Thank you.
Okay, thank you.
Thank you very much. My name is Dayo Mohamed Yusuf from one of the local NGOs in Nigeria. Thank you very much, the speakers, and thank you, the first presenters. I'm happy to hear the commitment from government, but as a civil society actor, most times when we hear things are integrated into policy and guidelines, we know they are sustained. But over time, most of the time, the policies and guidelines that are developed will end up as documents on shelves without financial commitment to really translate into replicating novel interventions like SBDC. So what I had expected to hear is the implementation has been done in 5 regions, covering about 140-something facilities out of over 11,000 health facilities in Tanzania. So what I expected to hear was what government direct commitment will be in scaling up across the region. Even if it is to say we are going to start scaling up to 10 facilities across each of the regions, something tangible. Yes, putting it in the strategic plan is excellent, it's wonderful, it's good for adoption, but most times there is no that financial commitment, especially from the Office of the President and the Ministry of Health. We end up having the strategy embedded in the government strategy, and then it ends up on the shelf. Secondly, also, we are aware that the development financing is being gradually declining and gradually even getting phased out. So what are we really doing to ensure that for the remaining years that we still have this technical assistance seated in the country, we're able to really leverage this technical assistance to really build capacity rapidly across the region so that this tempo will be sustained over a period of time. Finally, we know everything we do on SBBC is on the supply side. And no matter how much the facilities are improved, I also understand that the object of services for most of the locations it involves out-of-pocket payment. And we know the poverty level in the country. So what are we doing to also address the demand-side barriers, especially in financial access, to ensure that women in very rural communities can really be able to pay for these services or access these services free, as in free, not free in the policy, but when you go to the facilities, you discover that some payments are still, or some payments out of pocket are still being made. Thank you very much.
Okay, I think those are very great, good questions. They sound many, but I think they can be answered still right, because they are more about financial financing of health services, financial sustainability, and improving financial access. I give that to Dr. Magwan as a policy person, and then we'll come to Dr. Fauna later, particularly on the research in government priorities.
Thank you very much, representative of civil society. Yeah, it is true, the most important part is not just to demonstrate the evidence. You need to see how that evidence can benefit much of your population. So for us, 5 regions was a learning region. And if you followed my speech, maybe during the translation it might get lost, but I think you get it very clearly. We said, I say, in 2018, in Tanzania, we had 14 neonatal care units, called wards for the newborns. And during my discussion here, I say In 2009, 2010, we released the evidence about healthy baby decrease. We thought it is going to solve all the problems. But later on we learned that there are babies who need to be hospitalized to make them survive. And that is evidence is coming from the PhD study of Dr. Felix Mugabe. So what do we do with that 20%? We say we need to start having an address, everybody had no address in our hospitals where you can provide care. Understandably that the care for the other five is different from the care for the newborns. So we say the evidence told us that you need to start newborn care units massively. Fortunately, it is coming with evidence from SPCC, sorry. So we have done some scaling up. From 175 by 14 we mentioned in 2018, when we mapped in 2022 they were around 175. They were at 175. And now we are having a number of 362. The denominator for us, is all council hospitals. That is it, a denominator we are working. In Tanzania, we do have 184, I think, councils. 184 councils. So you can see the number there, it is reading 362. Where the other hospitals, these are likely to be the big centers and the private hospital. They may be not-for-profit or profit hospitals. We have managed to scale up the intervention to almost all regions, to almost all councils. The other question was financial decline. How do you cope with that heavy investment? In Tanzania, every penny that comes, the aim is to reach the grassroots level. Every penny that comes in this country, the government strives to make sure it impresses its people. So, all the funds you will see in our budget, you will see the budget which is set, you will see the newborn. We seek for some grants. When we get, you see a newborn. We take loans in the government, you see a newborn appearing in those loans. So that's how we manage saving. But saving, also we save by using innovations, how to get those facilities. I'm sorry to say, you may differ with me. Sometimes we differ to use tenders. Instead, we use the so-called law of artisans. In Tanzania, we call it law of goods. It is called the false account methods. So that we are able to replicate quickly at a cheaper price. That is making sure that we maximize every cent that we get. And then you talked about issues. There are issues with the out of pocket. We are the same. We are addressing issues of out of pocket to reach the population at large. And to do that, we have moved forward and we enacted, last year we enacted a law, which is called the Universal Health Insurance. We are currently striving to identify indigent households so that those indigent households that could be supported. That is making sure that we are addressing issues of universal health coverage. Because our measures of universal health coverage here is 43. We are far from 100 points. So all these we bring together to make sure we address the need for social services of our people, particularly in health. And this has been possible, I would say, having leadership transformation, which gears to address the needs of the people in the answer to every these difficult issues. You mentioned this is a period whereby there is a decline of support, and possibly you are mentioning what has happened with the drop of USAID support, I suppose. The government has addressed. One of the critical areas was supplies. To be sincere, and I want to record it to you. As a country, we got shaken as well. We got shaken as well. What are we going to do? But as a country, we had a catch-up plan. And I would say that catch-up plan, we have seen how much the government responded to make sure it puts a huge investment that we did not expect into procurement of medicines in the country. That's cut across from ARV, cut across from issues of productive and child health, all the medicines at least to fill the gap. And it is substantial amount of budget that was allocated to make sure we don't shake to that extent that we are able to deliver our commitment as a government, its commitment as a government. But we still call upon partners. The government has stretched its muscles to fill the gap, but yet the gap is there to be, that needs to have some support. So I would say, number one, you need a political commitment. That, I would say, it is there. Once you have a political commitment, fixing these other issues is easier. I could hear from my colleague, Mama just said, with this situation, how much do you need? And then Mama says, she looks at the Minister of Finance, are we able to catch up with this situation? He said, yes, we can catch up. We are done. That's how we have survived. So allocating every pen, making sure, maximizing that pen to make sure it reaches, the services they reach to the community is extremely, extremely important. I submit you.
That's a very good response. I think there was a concern. Of course, you were commended for taking up these innovations into policies and strategies. There was a concern of whether that would remain in just the policies. Now we understand pure life. After the ministry has formulated policy and guidelines, it is your job to make sure they are posted at the council level, as you say, and implemented. What do you do? How are you prepared to do that?
Let me clarify two issues that were asked by my colleague. One was, I think it was a response that financial sustainability is not important. I don't say that, but I mentioned domain of sustainability, that we should not only mention financial sustainability alone, as Dr. Makwan said. We have a political domain of sustainability, community engagement, but also sustaining the programmatic achievement itself. But really, the financial part is very important. But financial sustainability should be qualified with a very clear adherence to financial management principles. That's what Dr. Makwan has said. But really, there is financing gap. That is obvious. That's why you mentioned the moderator, the panelists mentioned. Since morning, the presenters mentioned and called upon the partners who are here, donors, that we need joint hands in addressing, not by 100%, but in addressing the financing gap. So, focusing on the locally available revenue was a means of local sustainability, but you really need multilateral partnership, bilateral partnership, but it was my commitment of effective financial principle adherence. But the other issue of linking the government priorities with the ongoing research, that was opinion. Whatever, maybe the new discussion, the research institutions will tell us, but they are really whatever the researches that are being conducted, they are going through the specific organs established by the law to see if the researches are there to the legal and regulatory framework, but if they are there to the national, regional, and global priorities. The issue of utilizing not only necessarily the advanced research that we're talking here, and the pure line I'm talking about, the implementation research. There are a lot of data, knowledge that we are collecting, a lot of data that we are analyzing. They are there in the data management systems. But what I was talking about, the evidence-informed implementation roadmap was to see the factors affecting or influencing utilizations of data available during routine correctional implementations of the interventions, project or program, and informing us in responding to some necessary area that needs attention. That was my real purpose. And I said it was supported from UNICEF, who have developed that evidence-informed implementation roadmap. And on that roadmap, we have costed it and also tries to analyze some factors that I say. Some people are not using the data just because they don't have capacity. They don't know how to use the data. So there are capacity issues. There are some unexplored priorities. Do they need some motivations? Or you need behavioral. Just behavioral issues. It's not necessarily that the researches do not align with the government priorities. Thank you very much.
Just a important point. It is good to understand that the financing modality of maternal newborn services in Tanzania and the assurance on how we can facilitate reducing out-of-pocket payments for these services. You want to say something?
Yeah. First of all, until now, the maternal and child care in Tanzania are given free of charge. It is a policy that has been put forward from 2007 and still it works today. There is a lot of discussions. Of course, when we say they are free of charge, does not mean there is nobody who is paid. There is somebody who is paid. And the government, with its partner, will ensure that the services are available free of charge. Of course, in implementation of this policy, we do agree it has hiccups, but it helps us to address quality issues, particularly making sure many people come to our facility to seek care. But also, I worked in one of the countries whereby these services were there, and cesarean section rate were skyrocketing. And somewhere around April 2010, they put an executive order which said it will be given free of charge. We saw the cesarean section going down, and we saw assisted delivery improving, and we saw improvement as well of the maternal newborn care. So if you let it, these services, if we say people are paying, of course it is an easy point whereby me and my colleagues, obstetrician and gynecologists, will harvest a lot of money from the cesarean section. We don't want that one to happen. We don't want that one to happen. We know there are some countries where cesarean section rates are somewhere around 80%. And when you go into deeper analysis, you find that they are at that level simply because these services you have to pay as a household. Secondly, to do that, we have an arrangement with our partners as well to ensure that we give enabling environment. For example, for us, maternal health commodities are given free of charge from family planning, antenatal, labor and delivery are given free of charge. And when you go to the primary health facilities, I think most of the services are given free of charge. We maintain that. We don't say we don't take hiccups to implement that policy, but we are saying that policy is a safety cap towards quality, provision of quality services. If you remove that safety cap is out, and people they will be looking how they can get a lot of resources from. This is what this is my reflection of the policy.
Asante sana. Asante. So, ladies and gentlemen, we have I'm told lunch will be ready at 1:30. So we have 15 minutes. We have 10 for the audience, and I will give the last 5 to the panelists. Maybe I ask you a question that you will answer at the end, each of you 30 seconds. If you were coming from Zambia to this conference, and you wanted to go and replicate what you have seen in Tanzania, give advice from your position, give advice as a director of an institution, advice as a regional implementer, advice as a policy maker, and advice as a president's office of Zambia. What will you do first? So that will be at the end of the panel. So questions, colleagues, any other insights? Yes, my sister. What happened from that? Any other hand? Yes, yes, Nalena. So you have 2 hands, 2 ladies there, and then you come to the chairman.
Good afternoon. My name is Anish Rasabula, a medical doctor from Zambia. And it's a pleasure to have such a wonderful panel before us. It's a rare opportunity. So my question comes from the fact that SBDC answers to the third institution, or the third delay, which is the institution. We have the second delay, and there's the program of MMR. I wanted to know how government, or what steps are taken or were taken into sensitizing the community into accepting these interventions. So, for example, the MMR program, would it be easy to carry out in nomadic populations or in very rural areas? Thank you.
Okay, next.
Good afternoon. I'm Lenny, working with EXA, East Central and Northern African Health Community. And my question goes to infrastructure. We know Africa is almost the same, and we have challenges on the internet connectivity, especially in remote areas. And most of these innovations, they require internet. So as Tanzanian government, how are we going to, or what is our plan for that? But also understanding the healthcare workers in the facilities are not enough. We always have shortages. Now we are intervening by providing training at the site, but the burnout is still the same. So what is the plan to ensure that the other side of the coin is also tackled, to ensure they provide quality care with the skills they require during the training? Thank you.
Asante leo, mwenyekiti.
Okay, thank you. My name is Peter Maduki. I'm a board chair of Highland Woodland Hospital. I have just a contribution from what has been discussed in terms of sustainability, particularly in the area of financing. Of course, we have a gap of financing when it comes to the maternal, newborn, and the child care. So we have the gap, but there are also mitigation measures which have been taken place. The government clearly stipulates that this is the free services, but we need to look for other sources to fund those to fill the gaps which need to provide the services. I'm talking from the private services and from the FPOs, Federal Organization, where we are supervising about 965 healthcare services in Tanzania. So actually our vision says clearly that the poor has to access to free services. And so we are obliged to look for another way of funding. So we have been looking, number one, first of all, this SBBC is an opportunity to the private sector, particularly the FPOs, because it improves the quality of care in our facilities. By improving the quality of care, it brings many customers. So I'm using the word customers. So the customers come to us, and when the mother comes to deliver a child at our facility, it means that if found that we offer quality services, she will also invite others. So we get more, and that money it is instead used to cover the gap. But the second option is the question of market-based approach. Those who can pay more, they should pay more and get the money, cover the cost. So there are other services which are not basic services. Like if you want to stay in a VIP room, you'll pay more. So if you stay in a VIP room, then you'll pay more and the money will be used to cover the gap. So those are the strategies which we are using to finance, and actually is one of the way of sustaining our intervention of innovations, which like the SBBC here. This is what sustainability is not only money. Sustainability is also an issue of leadership and management. We are urging our bishops, or those who own the facilities, actually to appoint a competent board. Because these people, sorry, there's no bishop inside. Sometimes, we started this for our last 4 years, whereby we found that we did an assessment in 22 facilities. And when we looked on all members of the board, almost more than 50% didn't have the qualified people sitting in the board. So we advised them to change the members and bring in the technical people so that they can support the hospital to run efficiently and effectively, and also raise it. So for us now, we have gone to another step in order to sustain the SBCs. We are looking on the minutes written in minutes of the board. Is there any key performance indicator being discussed in the board in regards to maternal and newborn child care? For example, if there is a death, is the board really discussing it? Is this really you don't know, this doctor always comes during the meeting and comes saying, you brought them very late. That's the oral statement they always put in their report. And we answered, yes, the mother brought very late. But what did you do when she came to your hospital? And then Dora starts, start still talking about giving me these jargons so that I cannot follow them. Then what I want to say is, maybe I will recommend particularly to Pure, because you are You always see these boards, facility governing committees actually look on the way they are formed. I know there is that guideline, but that guideline is outdated. It was, I think, in 2013 was prepared. If I go to the referral hospital, actually there is a proposal which was developed in 2016. So I want to see very strong board, but not only having a board, but really discussing these issues in the board. We have these plans, but sometimes these plans, they don't give the key performance indicators on that end. So this is an advice to my colleagues here on the plan. Thank you very much.
So we will respond to that was an advice, and it doesn't need a response now, but we have 2 questions. So talk about the infrastructure, the internet with your innovations, and then bring it back to the government.
Yeah, thank you very much. And because we are in a rural setting, and most of our research...
Sorry, Dr. Mboya, as you finish your response, you can also give your final word of my question that I asked.
Okay. We are in the rural setting, and most of our work has been in the very rural setting in the village, where the internet connection is a problem. So I will assure you, you don't really need the internet all the time in the very remote area to put up the innovations. So you can still have Mama Natalia, you can still have Moyo, you can still have Neobiti, you can still have all the innovations in the area where there is no internet. So internet is not a limiting factor for you to take up the innovation. I think that's okay. And to finalize what I've been asked by the moderator, if you are to take the SPDC, if you are to take this innovation to your country, as a host or a leading institution, what do you need? I would like to echo the words of my chairman of the board. The governance is key. The leading institution should have a strong governance which is efficient and effective to take the initiative forward. And in the governance, what you need, apart from the body, you need a governance who has a very good financial stewardship. You have to have a good way of managing the resources that you have. You must be able to manage human resource effectively. You must have a strategic ways of managing the project. You see the impact, you see the results that we have achieved in the SPDC. It's not only the intervention, it's also the hydrothermal hospital management that has huge input on this. But also in the management, you must have a collaborative skills. You must be able to manage donor funds. You must be able to comply to the requirements of the donors. But also, you must bridge yourself. You must connect yourself with the government, because the government owns the facilities. If we are not in good terms with the government, it would have been very impossible for us to achieve what we have achieved. But you must have the right people for the right price. Thank you very much.
Perfect. Yes, mtu kaendelea sana kwa kikulo za mwisho. Sister, kama RIC kwa Zambia.
Thank you very much. For me, I advise my colleagues to make sure that in every project which is coming in their regions, their districts, they have to let the regional and district to be a lead. The regional districts lead the approach in the facility also. They have to make them all the interventions, starting with the in charge of the facilities and the region and district level. If they own their interventions, they can intervene them in the sustainability plans. So when the project is well out, then they can continue doing the intervention which is intervened by the project. So the regional and district lead approach is very important to all projects which is coming into the region. Thank you.
Wow. Yeah, I think I'll take the challenge and contribution from Mr. Peter Maduki about issues of leadership and exemplified as how the governing board of the facility can operate. I do concur with you completely that that is a good approach. And I remember in one of the hospitals I was a board member. So we do have several committees, including the health services. Initially, they were bringing information, but you see the information, most of it was bookish. And then one day we challenged, we said we want to see service delivery data. So they started bringing service delivery data, and later we told them we want to see the reports about them. So they started producing reports about them, and then we started the zero around the maternal death. Then we asked them, can you clarify each day what happened? We saw those answers that showed they were not coherent. And then we gave a sweeping statement saying that we need to make sure that your committee is operational, because you can see here there is no operational committee for maternal and perinatal. And future reports you could see the detailed reports about each death which was being brought to the attention of the board. And that helped us to design even some of the interventions which were life savings. For the virtual maternity I'm talking about here, for example, we saw there were some challenges when we were using the recommended method of maternal death review, maternal and perinatal death reviews. We didn't get issues. Always there was a blame to the community. Always there is a delay. But we don't see that intrinsic approach of evaluating yourself. When we started the virtual maternal death reviews, we saw over 80% of deaths, issues of skills and knowledge were coming out. Over 70% of deaths, we show issues of practice and attitude are coming out. And there, somewhere around 40%, we saw issues like leadership of the facilities are coming out. So, when you have a very good review, you have very good output. Last but not least, I'm a candidate of PhD, a PhD in need, I call it. We have been examining the routine data use in our setting, and I was looking at the use of routine maternal data. What we found in Tanzania setting using 2 regions and abstracting data from for 4 years, we have seen the routine data when compared with our gold standard of choice in those 2 regions, were representing of 0.89 of the gold standard. If the gold standard is taken as a unit 1, then the routine data was representing 0.89. I've seen a paper from Zambia. Somebody published about routine data. I've seen a paper from Rwanda. Somebody published about maternal data from routine data. And there is a lot of discussion in Netherlands, in the US, in France, in the use of routine data. All of them, they say routine data may be used, but there are issues of quality of routine data, regardless whether it is developed or undeveloped countries. So I would call upon, especially at this stage, where the DHS is unlikely to be one of the tools, and again looking into the quality coming out of DHSs, there are issues with those data coming from DHSs with very, very wide confidence intervals. Let us go back and they are examining our routine data. Let us go back and put leadership in making sure the routine data are available. I submit to you. Thank you.
Thank you very much. Responding to the question on challenging or addressing the challenge of second delay through a MAMA program. It's now an intervention that has already been taken by the government. Let me provide clarification first that a MAMA, even when it was under its pilot phase, was not meant to replace the existing referral system, the government referral system. Rather, it came to strengthen the existing referral system. Within the only 4 years of the leadership of Excellency President Samia Suluhu Hassan, she has managed to increase, procure, and distribute to the rural areas more than 528 brand new ambulances. Basic life support and some of them being advanced life support ambulances. At the same time, from April 2022, the government adopted officially the MR, especially focusing on the second delay in emergency transportation, emphasizing the role of the government on emphasizing public-private partnership by making use of the private community tax owners who are trained and are there with the acceptable minimum standards for transportation, and making use of digital platform and making use of community-based systems as well. So for those who are not very much competent with the imam, when there is a need for a pregnant woman or a non-nurse to be transferred, whether from the facilities, but for those regions that are already, I think most of the region now, and mama can respond to a referral directly to the community. So when they receive the call from the community, from the dispatch center, it's not the dispatch center directly who call the community task. No, they call first the ambulance that is only the ambulance. The purpose is to make use of strengthen first the existing government systems. And the previously existing ambulances were just minimal challenges like lack of fuel before this MAMA program. Some of them were just no tire, just a single tire, but because those district officials knew that under MAMA, the first point of referral with existing government ambulances, it increases accountability of the ambulances. So with strengthening this MAMA system, especially with government, and adopting it or joining with the community taxes, it has significantly increased or addressing the challenges of the second delay. And also with strengthening the integrated and coordinated community care workers program, whereby at the community level and at hamlet level, we find every hamlet, there are 2 community care workers, a male and a female, and they are located outsourced. So whatever is happening at the community level tightly, especially those that need the referrals. Let me finish this. Yes, you have time to clarify. So which means there is no other challenge of not responding to the call for referral, whether call from the communities or call from the facilities in addressing the second delay. There are some social, cultural, behavioral issues that we are trying to focus on in terms of education and promotions, especially at the community level that affect healthcare in the areas. So I think with the mama, you can have more time for those who ask the questions. Maybe after these sessions, we can meet together with Dr. Mangwani and the team from Minister of Health for more clarifications if you are aiming at adopting it at home, where you are coming from. Internet infrastructure, let me tell you, more than 6,000, now 7,000 primary care facilities. We have installed the Government of Tanzania Health Operation Management Information System. That is web-based. And this SaferBirths is centralized at Dodoma. Dodoma is the headquarters of this country. So it's centralized. So when we are there now, we can see what is happening in the dispensary at the lowest level. So that's to say, with available internet subscribers of several, but with the government subscriber of TTCL, we find it most accesses most of the remote villages. 2 days ago I had a Zoom meeting, virtual meeting with CHMT, the Council Management Team at Chipkipwe, just neighboring Zambia. There was some events there. Very far. Other internets we are challenging, but the government commitments ensure most of the government's internet reaches hard-to-reach areas. That's why I say the government political will is very important for addressing. But if there are areas that completely there is no internet, our modalities, most of our systems allow offline mode. So they can enter data at the area where there is current facilities, where there is no internet, but when you go to the internet, they can still upload. So the internet has, resulted from SPBC saying, it has not been a very much problem, despite the fact that there are some areas, and the government has been continuously improving that. We are working together with the IGA, with the Minister of, we're not working alone. So even if we are going back home, not saying it's not the Minister of Health alone, we must work with other ministries that are concerned with telecommunications in order to fasten it. And the ministers to speak on behalf of the sector when talking at the parliament, they are all contributing to the paper at the parliament. But I remember in other African countries, yes, the problem can vary and can be much more bigger. So the issue of Council Service Board, Maruki, you are very right, and these guidelines for establishment and operation, because I've been working as a district medical officer for quite long times, I know most of these guidelines were prepared many years ago. And even the indicators for assessing functionality of the Council Service Board, the specific governing committees, most of them were the output indicator, like the number of meetings conducted. You are supposed to conduct 4 meetings in a year. So when you tell us you're conducting 4 meetings, so what? Should we clap hands and say, congratulations, 4 meetings conducted. So we need at least the level of outcome indicators, or the number of household enrolled into the insurance, the co-function of the board. So with the UHI, with the advancement of technologies, with the various guidelines, I think it's very important to review. And as you say, and as Dr. Mangwani said, also to revisit and digitalize the key performance indicators for Council Service Board, for specific government committees, but also in the NC. We need also to do the capacity, implementing the funding for training and making sure that these Council Service Board, specific governing committees are really functional. Because they are very important government, lower level government governance structures in a process of decision making, especially for the government. It's very important to our boards, very important to our specific governing. And specific governing committees, they are representative from the villages, social service committees. So there are a lot of issues, including even the issues of SPBC, that needs the community attentions that can be discussed in the last year is about human resources for health. I said it before, and it's very important to continue with the process. As a country, during the annually in Tanzania, we budget for personnel enrollment estimates. For example, for the past 4 years, more than 34,000, we enrolled more than 34,000, but we have been collaborating with various partners. So calling upon with partners who are here as well, also let's enhance the government in terms of putting human resources, whether in contractual basis or in other modalities. But even the council, the districts, using their own sources of funding, and this facility have been allocating funds. Despite the number of staff employed is very little, but at least they are showing that initiative of addressing the issue of human resources. But thank you, SBCC, for training. Training is very important, and also the distribution. The distribution is very important when looking into assessing the ratio of healthcare workers vis-a-vis the workload. So I will not respond about if I am director of social affairs and I'm in Zambia, because I don't know the working arrangement, the legal and the regulatory framework of Zambia. Okay. The resident solidity plan of Zambia, they don't reflect content of our negotiation in Zambia. I think after discussing with the Zambian representatives, I can be in a position to advise. Thank you very much.
That's a problem when you deal with the diplomats who know their boundaries. They don't want to start a political war with Zambia. There was a hand, but I won't take that hand because we are short of time. I will encourage my brother to lead the panelists after we adjourn. But ladies and gentlemen, I want to ask us, all of us, to raise and give a big hand, a very big hand, round of applause to our I believe we all enjoy the talk, right? Yes. It is a good appetizer towards lunch. So we have 45 minutes. I will request that we come back here at 2:30 for the next. Enjoy your lunch.
Lunch is served outside this building, so just go outside and grab your lunch. Just outside of this building.
here? Lady Dr. Juliette, please come on stage. So we will start. I know we are missing Dr. Dio, but I'm sure we will catch up very soon. So we'll start with another few kind of leading questions to the panelists for us to be able to learn how SBBC lessons from Tanzania can be applied or replicated in other parts of the world. I will start with Dr. Funke, then I was planning to talk to Dr. Dio if he's here in time. Then Tingbit, we have Dr. Juliette, and then Dr. Regina from GFF will be the last to provide the remarks. So, Karibuni, I think I will introduce you very briefly, but you feel free to say more when you have a time to speak, so that people can know who they are listening to. So I will use each of you as a kind of directed person. So Dr. Funke, I understand that you work with Italy. You are the country director in Nigeria, but also a deputy vice president of Chai globally, right? So a very big person. So I think the audience will be very interested to learn that Chai has already started implementing SBDC, particularly in Gombe State, as part of the larger maternal body program. Can you share with us why you decide as Chai to integrate this SBDC program or innovations into your program? Welcome.
Thank you, everyone, and I hope we had a good lunch. Welcome back. So, Gombe State is in northeastern Nigeria. It's a fairly small state in terms of its relative population compared to other states in Nigeria. However, it's also a very rural state and had lots of issues with maternal mortality, newborn mortality. We had some funding from the Gates Foundation to support the implementation of group antenatal care counseling. I don't know how many people are familiar with group antenatal care, but there was some research that Chicago had done a couple of years ago that showed that group ANC was an effective strategy to link mothers, especially in Nigeria where you still have more than 60% of deliveries happening at home. It was a good strategy to link mothers to facility services. It increased uptake of institutional delivery, and it also sustained retention so that they could get postnatal services. So the initial investment was to drive group antenatal care and bring people to facilities. Of course, you don't want to bring women to facilities where there are no services. And so it was critical that we also build capacity for the delivery of facility-based services, right? And so part of that was we did an OSCE, objective structured clinical examination for the health workers in the facilities we were supporting. And we were alarmed by the results that we got. Nurses, midwives, community health extension workers did woefully, like it was really bad. In things like managing PPH, we got only about 30% that could effectively manage PPH based on the clinical protocols and guidelines. Generally, their knowledge levels were very low, despite years of investment in Gombe. Fortunately, we had several engagements with the LIDL group that had been in and out of Nigeria, talking about SBBC. They had shared some of the resources. And so internally we thought about it that it didn't make sense driving demand for facility-based delivery without addressing the capacity gaps of the healthcare workers, right? So that when the mothers come, we ensure that they are not dying for poor quality of care due to lack of capacity to deliver. So that was really the rationale. And it made sense to adopt that model because we thought it would also be cheaper than the conventional sort of capacity building that we had been applying, the LSS model, where you have to take health workers away from facilities for weeks. And that also has its negative impact on service delivery. So I hope that answers it.
Sure, it does. And people have time to ask the questions if they have. And so I think we learned from you on the adaptive management that you created a solution for one thing, and then you realized there was a problem, another problem, and you find another solution. So I will appreciate if I get feedback whether Dr. Dio is coming or not.
He's running back. He was talking with his friend.
Okay, no problem. I mean, there's no punishment. You'll find us, going there. It is very important these insights. Very important. So since it, I think Daniel is starting. I was informed that the Norwegian Church Aid already partnered with the Borno State in Nigeria, and they are also working with Idaho and the Northern to start the pilot in Borno State. Could you tell us about the implementation, the status where you are, and what are you seeing so far?
Thank you so much. Good afternoon, everyone. So before maybe saying something about our implementation, I think it would be only fair to start what we have planned for SPBC in Borno and Northeast Nigeria. So our plan is to implement SPBC as phases. So we classified it into 4 phases. It's not according to the package that it includes as an SPBC phases, but it's depending on the locations and also the facilities that we want to cover within 4 years period. So phase 1 is only in 1 LGA, but 4 facilities. And then gradually, when we complete the 4 phases, we are planning to cover at least around 300 facilities in Northeast Nigeria. Yeah, we recognize SPBC is already in Gombe, but our plan is to expand it in other states in Northeast Nigeria. So that is the plan, and we were able to get funding from NORAD to implement phase 1. So phase 1 has 18 months. And we started implementing it this year, January. And all the processes have been there. And then we, of course, started by selecting champions, mentors from the 4 facilities. And also, I think before saying this, I have to recognize that SPBC is mainly implemented by Borno State, Ministry of Health, Borno State Primary Health Care Development Board. We as MCA, we are there to coordinate the efforts. And also, we are partnering with Haidam Lutheran Hospital and also NADA Global Health. We started from the selection and everything, and then we trained 16 healthcare providers, 4 of them as mentors, and also 12, which is 3 champions from the from each of the 4 facilities. That makes some 12 champions. So actually, those of you who were with us in the same bus when we came from Arusha here, I think you've noticed Dr. Robert mentioned one challenge when they started or implemented SPBC here. The later ward in charge were not part of the champions. So we took lesson from that. And then we included labor ward in charge as part of our champions, and then the training was conducted in Gombe together with Chai, and of course the trainers from Haida in Ladakh. So afterwards, the next, or what we did simultaneously was procurement, right? Because these equipments need to be procured and shipped. So because most of the time when we hear international procurements, we all will like anticipate prolonged process and everything, right? But for us, we were lucky because of the support from government, different ministries, and also I think I have to recognize the HGH team in China and also Norway. The process was really swift. We were able to ship the equipment into the country, I think in less than 3 weeks max. And yeah, afterwards we had flagged it off, we distributed the facility, the equipment in the facility. Yeah, and then the next step was to provide facility-based training, because all the providers are also supposed to be trained, and also we need to make sure that the facility in charge and the mentors has what it takes to cascade this training on a regular basis. So that was also some of the preparation or initial process that we have actually accomplished. And then since May, we have started the full implementation, which is like the SimBegin or the simulation have started on a daily basis. The health professionals are using the training corners that we have established in all the 4 facilities. Yeah, so they have started the training, and all the clinical tools were also being like used. So far, I think I will distribute some information sheets for you guys so that you will be able to get information on the results that we were able to achieve so far. But so like for the 3 months, and I think from May to end of July, in these 4 facilities that we're supporting, there were around 904 deliveries, and of which 353, the facilities or the champions or the health professionals who are working in these 4 facilities were able to use Moyo on like 653 patients, and they that supported them to do an early detection, and they prepare themselves to what's coming, and then to resuscitate 57 asphyxiated babies in these 3 months. So yeah, these are some of our achievements. And yeah, as I said, in SBBC, we are planning for it to be implemented in phases, and we were only able to secure funding for phase 1. That means we still are looking for donors, partners, stakeholders to fund, to collaborate with us, to work with us, especially on the remaining phases, and also MCA and farmers administrables. I have to say this because we have the political support commitment from the state, and anticipating the same will happen in other states. We really would like to expand SBBC in the rest of the states in Nigeria, so that we will be, we will ensure that mothers and newborns will get quality care, respectful care that they deserve. Yeah, thank you so much.
So a few words. It is the Minister of Health in Borno State implementing this. They want it, they need it, they are implementing it. You are supporting them with the technical assistance from collaborators, but also with the mobilization of resources. Perfect. So Dr. Dayo, welcome. When we were not here, we had deliberations, and the people agreed that you should get the toughest questions. Dr. Dayo is the director of the MAPI program in Nigeria, and he also a former commissioner of health for the Ondo State. So very informed and experienced figure in Nigeria. And we were informed that the Minister of Health in Nigeria said that he aimed to crash maternal mortality, bring it to 0. And Dr. Dayo was the man who could shoulder that burden to lead the initiative with the NAMI program. And they have been working some time on how SPBC could be integrated into the MAMI program. So, Dr. Dayo, what are the main lessons learned that you take home, and how do you feel it aligns with your program back home from this workshop?
So thank you very much. My apologies, I can do it. Yeah. So for MAMI means maternal newborn reduction ratio initiative. So basically what that means is that we said it with all ambition on crash and mortality. And what is more is the fact that before you reduce, it means that maternal mortality is very high. And very similar as we speak. With what we started with in Tanzania, our current ratio is around 512 per 100,000 live births. And I recall it started with around 5 over that too in Tanzania. So we need to drive that, we need to reduce that. And that's the vision of the president of their country, Nigeria, President Bola Tinubu, to crash maternal mortality and the needless maternal deaths. So with that vision, it was clear that with the huge investment in time past, we have not made much progress. In fact, when you look at the mortality, for the last 1 decade or more, using the NHS, to be clear to you how we have been oscillating between 545 and then how we got to 575. And then we came back to this 512 within 1 decade, 2008, 2013, and now 2018. So that clearly showed we need to then innovate before the need for innovation. And if you must innovate, then what do? So in line with the directive of the coordinating minister from Professor Mohammed Ali, let us understand where these women are dying, and let us understand why they are dying. The first thing was the 172 LGA with the Director of Family Admissions. The 172 LGA is contributing to 5% of our maternal mortality across the country. And these LGAs actually, they are in the 3 states. And the truth is that if we focus and intensify our efforts around here, we're going to be crashing our mortality by 55%. Then what is more, is that why are they dying? And I'm sure I was talking to my friend who knows just 3 delays, but for us in our country, we know 5 delays. So the delay, in seeking healthcare, the delay, in reaching healthcare, and I've heard about the third delay here, the delay in receiving healthcare. And for us, we are then the delay in taking responsibility for IFRA, because that's a huge delay. And then the last one, which is the most critical delay actually, is the proper coordination. Even though here you are trying to address that, so you will not know. But we found this as a critical gap. Because here I've seen the way you bring in the emergency, you bring in, the Federal Ministry of Health. I've seen that, you don't have a primary health care here, but I see the way you work with the POLAC, right? POLAC, yes, which is the primary health care component. So even though you kind of do the coordination, but for us it's a critical delay. There have been no time where all of these people are working with the purpose of saying, let us crash maternal mortality. So that delay of coordination is the 5th delay we have had, and we know that we are beginning to see evidence that will give us clearly that this is a real delay, and that's why our maternal mortality, because each of these agencies used to work in different directions. And so with that, we were not able to address crashing maternal mortality. But now that we know our problem, we know where they are, all of us are working in that direction. I tell you for free, here in this room, I have those multi-agencies right in this room, the Director of Family Health. The head of the emergency is right there. I have somebody from the National Primary Health Care, is also in the room, and I have somebody from the National Health Insurance. All of us are here to learn, so we have one shared vision. The country adopted actually the sector-wide approach in terms of crashing maternal mortality. That means all of us here have one plan, we have one budget, we pool our resources, and then we have one report, meaning our indices are the same. Whatever I speak is what other people will be talking about. We're talking about 512 per 100,000 live births. If you ask anybody, it's one report. more conversation and one voice. So with that lens, we then come up with a strategic framework for Mali, and it has like 6 thematic areas. One is to see how we engage the community through the National Primary Health Care, using the community-based health program, doing the listing of every pregnant woman across, these LGAs, and then linking them to the facility already developed, and then ensuring that they track them to come and deliver. And then secondly, the second is the access, ensuring that it's both physical and then there's a financial access. The physical access is in terms of this emergency transportation for every woman in need to eliminate that delay, in reaching healthcare. And then the financial access, which also can be responsible for seeking healthcare, means that for women in need of emergency situation section, it is free by the National Health Insurance Agency. And this, means that the woman is subsequently enrolled, into the insurance program. And this is prepaid, by government. CMOC facilities, that means tertiary, secondary institution, tertiary institution have been empaneled to cover these serious sections. And as we speak today, around 200 facilities are paneled across, the country. So some of them are these Miami LGAs. In fact, about 20 of them in these Miami LGAs. And they have done, as we speak today, over 4,600 sections free of charge. And the emergency, access that I talked about. As we speak today, 4,128 women have been evacuated. And so the beauty of this is that, and you come to the third aspect, which is ensuring that there is a ready facility to receive this woman, either the BMO facility or it's a CMO facility. And this is being done, BMO by the National Primary Care, and then the CMO, also done at the primary health care, the NHIA, as well as the swap office, so there's a sector-wide population office. And then, of course, the need to also track every unfortunate maternal death. And this is done at the Federal Ministry of Health through the MPCDSR, and I have the lead for that right in this room as well. And now, so importantly, the other two parts are the enabler, meaning we now need a kind of digital platform to be able to coordinate all of this. Meaning, a woman is registered, is listed, she's a high-risk woman who is unlikely going to deliver. By herself, needs a social section. There's a planned emergency transportation using the digital platform, and that's also how the digital in health, need for inside this room as well to understand. And since they're going with Hello Mama, and I know these other people have been studying what you're doing to see how we can improve our own. But, critically last part is the sector-wide, coordination, meaning coordinating all of this using our platform at the state level. We have the Miami Task Force. At the local government level, we have the World Development Committee. At the federal ministry, we have the coordination, Miami coordination team, of committee. And then, of course, we escalate this to the steering committee. So all of this, putting it together, we now came to look at 172 LGAs. How many of these LGA have the minimum viable package to be able to deliver services? We now categorize them to be into 3. 20 of them have the BMO, have the CMO, have community-based program, emergency transportation. And then with these 20 LGAs, we know they are ready to offer services. Then we have another one, that 11 that has BMO but do not have a CMO, and then we have the other 32, thereabouts, that do not have, this boat, So what we are starting with, and the lesson I learned here, is that for SBPC, right away another categorization analysis also found that 42 of these LGAs have issues around quality of care. And then thirdly, the last survey conducted by the Liverpool School of Tropical Medicine also showed clearly the issue of capacity. And so with all of that, we know clearly we have to strengthen our EMOC, which is the emergency maternal and newborn care. And that's what informed the first discussion we had established. And then now it's a continuum that we're here to now see, because from there Benjamin presented, and I found the LBC very interesting. All of us with all of us that went there with the DFH. And we said, let's go and see more about this. So we're happy to be here and the lesson we've learned. So interesting now when we get back, we will be looking at those facilities that are ready, we have to face it. The resources might not be able to go around and go. So we will look at those first 20 LGA using the Bono, champions. Perhaps we might even upscale them to become faculty and then be able to now scale up those ones first. And then as we move, because of course process is always with the NHIA to move another 70 from the 111 that do not have CMO to be empowered. So then we scale on to that, and then like that we go down to cover the 172 LGA. And this is a target we need to must achieve. Even though ambitious and tall, but we know it's doable, before this year runs out. So for us, from the lesson we are learning from here, from SBBC, not even only SBBC, even the health, we are integrating all of that to improve the quality of care. And what I found interesting is the fact that you can use the data, in the SBBC to be able to track performance and then be able to take decisions. That's why I was listening to the last panelist, because they show clearly how policymakers can actually use the data. All of these are learnings that were picked. In fact, I love the WhatsApp group. I was sending the FH. I said that's quite innovative, so I can get some of these kind of agencies to be on those WhatsApp group, and then we can be sharing the outcome, from the data, and then they can use it, to take decision as we journey. So let me tell you clearly, the trend is going. We're making a progress.
Maybe we'll take a break.
Okay, first, thank you. Thank you so much.
Because I was trying to write, and already I have a country strategy for paramedication. A few things to highlight from Dr. Dayo's narration. One, he highlighted the importance of coordination across the offices and the sectors that are responsible for programming of maternal newborn health. He talked about the importance of looking at the continuum of care from community facilities, but from antenatal to postnatal, which is very important. And he talks about enabling both physical and financial access to the services. Now, it is a very way that I could transition to our neighbors, Kenya now, Dr. Juliette. You have all the innovative ideas from the diet that you can incorporate in your response. You are the head of newborn and child health in the Ministry of Health in Kenya, right? And we were together the day before, in the field trips where you looked at experience from the facilities that are already in SBDC. What were your takeaways, messages, and do you see the potential of implementing SBDC in Kenya?
Thank you so much. From the trip that we went to the district hospital, I'd say it was quite eye-opening for me and Dr. Milka, who are from Kenya. Why this was eye-opening is because my first interaction with SBBC was in South Africa, where Dr. Allison presented on the strikes in Tanzania. And being our neighbors, I was really wowed by the fact that this is happening next to us and the numbers are going down. Right now in Kenya, our newborn mortality rate has stagnated for more than a decade. We have 21 per 1,000 live births and our maternal mortality rate at 355 per 100,000. And this initiative, I had interest in it, but now bringing it to reality is everything that we wanted as a country to see it happen. So this opportunity was great. Now when we talk about our newborn and maternal mortality, when analysis was done, we realized it all boils down to quality of care. And quality of care mostly was healthcare workers being empowered with the skill to attend to the mothers and the newborns. We noticed there was a gap when it comes to it. So as you can tell from this question, Kenya currently is not implementing SBDC, but we have interventions in place. We talk about maternal mortality and strategies towards it and empowering our healthcare workers with the knowledge and training. We have our EMO trainings, we have our continuum of care, and despite all this, these are one-off trainings that happen, and people on the ground, their healthcare workers, seem to lose it afterwards. For the newborn health trainings, we came up with the comprehensive newborn trainings that we've been able to train those in the newborn units across the country. And also we realized that we need a mentorship package, because once you train, then what's next? How will they be able to impact and improve on it? With the mentorship package, we also came up with a simulation training, which these are just avenues where we had discussion and we are thinking, where can we plug in when it comes to SBBC? So during the field trip, one thing that stood out for me is that district hospitals are actually doing simulations. In my country currently, we are not doing simulation at district hospital level. And it's a plus going back to tell our leadership that it is actually happening next door. District hospital level healthcare workers are doing quite organized, and they're very confident when it comes to simulation and use of this technology. Another gap that it's a plus for Tanzania and a gap for us is technology like oil. For us, we do not have them, but we see that with this gap, it shows that once we are able to invest in acquiring these important instruments when it comes to maternal and newborn health, there will be change in the reduction of maternal and newborn mortality. So despite our country having high rates of skilled birth attendants and most of our mothers being able to deliver at facility that's at 89%, it is good to learn from the Tanzanian team, going to a district level hospital and seeing what can be done for us to go back home and but ensure that we implement this. So also the area when it comes to champions, that was an eye-opener for us too. Having champions helps not only champion for themselves and the newborns, but motivates the staff who are in those facilities. The referral system, M-Mama, I've been here and I'm also happy that it is working in Tanzania. We have referral systems at Ministry of Health level, but not as granular as how this M-Mama is tied specifically to the mother and the newborn, which is an area where we need to think through as a country, how do we improve the referral system, because most of the time the mortality is due to the delay that can be averted. So in terms of collaborations from Kenyan aspect, we have the GFF team who have been very supportive. There's someone here from Chai. Chai is also very supportive to us in the country, and we work closely with Nest 360. These are organizations that are actually keen maternal and newborn health, leaning towards more of newborn. But there's an opportunity for us as a country to start this. And just from your question on do I see potential, I see quite a big potential, because this is a discussion that I've already escalated to my leaders back at home, that we need to have this discussion to ensure that our numbers fall, and it might be the last click to us unlocking this stagnation and ensuring the maternal and newborn mortality drops.
Perfect. So I think that's a very great narration. It's good that you already started taking action by accelerating some of these issues to the senior leadership. You acknowledge the use of simulation-based training, the need to have such innovative tools, both in training and in clinical care, and then the use of some processes like champions to make the things happen. Every one of you talked about the collaborators in terms of resources and getting this work. And we have GFF representative here, Dr. Georgina Musemo, who has done an incredible job working with the government and the partners here in Tanzania. But I want her this time to reflect more on a global perspective. If GFF is already supporting the scale-up of the CBC in Tanzania, do you see, now not Dr. Georgina, but as GFF, do you see GFF any potential for scaling up CBC in other countries? Can people count on you? And most importantly, is this something that countries have shown interest in? Do you have any interest from one of the countries, or would you want to ask them to show interest?
Thank you, moderator, and thank you, members, participants, for showing interest on this SaferBirths plan of care innovation. GFF, somebody maybe, not all of us know what is GFF is. It's not an enemy. It's a multi-donor trust fund with interest to invest in countries, specifically the investment to reduce or to accelerate the reduction of maternal child births and mortality in countries. GFF, actually, its operational model is based on the principles of country-led, responsive to country needs, and focuses on building government leadership and systems. For Tanzania, actually now I'm speaking on behalf of the GFF Secretariat, Lady Dr. Morgan, Alison Morgan, who was supposed to be here, but currently is having another call. But in country, I'm a GFF country coordinator for Tanzania. So, in phase 1, when SPCC phase 1 revealed the results, everyone was interested to the extent that the GFF thought this is a very good innovation to take up to scale. So for Tanzania, we are blessed from GFF Secretariat, from the Trust Fund. The country managed to be allocated another additional financing, which were co-financed in the World Bank project, TIM, Tanzania Maternal Investment and Child Health Investment Project. The additional financing was just to scale up SPCC Plus. And this should be led by the government using the governance system. Now, on your second question, of seeing the interest, when we had another conference or retreats in South Africa, that's where these results were shared to countries supported by GFF. There are 6 countries supported by GFF in Africa, globally as well. So there are countries that showed interest. Among them are here: Kenya, Zimbabwe, Zambia, Malawi, Cameroon from western part. Cameroon also showed interest, and Uganda also. Actually, they did, but when you can say you show interest, but you have to act. The interest per se is, I think, questionable to me. If you show interest, you have to take another step. Okay? But globally, when you say you show interest, you have to make something. You're requesting for support, maybe for innovation. And actually, GFF Trust Fund money is linked with World Bank projects. So if countries show interest, but maybe they don't have World Bank supported investment, it is very difficult to have a core catalytic fund from GFF Trust Fund. So they can show interest, but if on the ground they don't have World Bank project running, it is also another round. So there are current countries that have shown interest. I know that Nigeria is having World Bank projects. Okay, it depends on I think there's some criteria for that, and currently we've had the Norwegian support. So another thing there. So I can't say for sure that Nigeria is among the one that is on the list to be supported by global financing facility globally, or in spite of having World Bank projects. Yeah, because they have also another support. So GFF looks into countries that, okay, their investment is minimal, And the investment could be a catalytic to their projects. Yeah, I think that's enough.
So, if I can summarize, there are countries that have shown interest. Countries are welcome to show interest, and the GFF is willing to support countries showing interest.
Yes.
Good. That's a very good summary now. So, ladies and gentlemen, we will have a session, a Q&A session, but before that, I want to welcome additional panelists. And I will apologize, I think my three colleagues, I will move you to this seat so that the other three seats can be occupied by the new panelists. So next we have Dr. Emily Carvero Hines. Please welcome. She's coming from WHO HQ, heading up their work on integrated emergency and critical care. Welcome. Have a seat. We also have Dr. Lauren Liking, who is the CEO of the African Federation of Emergency Medicine. And we have Dr. Joseph Kalensi from Uganda, the Vice President of the Federation of Emergency Medicine. So we are talking about emergency and critical care, and Dr. Emily, I want you to just introduce us to this. Yeah, you have like 3 minutes to say something, and then I'll have some questions to the two colleagues. Welcome.
Hello, everyone. I think this one's working now. I know, what I really want to say is, hello. I love that call and response. In fact, I turned to my BBC colleagues and said, hey, by tomorrow, we want one for the basic emergency care force. So if you come to the session tomorrow, you can see us all get up and dance for you. Thanks for having us up here. It's wonderful to be able to talk about this today. It's really just a privilege to be here today with you guys at this important SaferBirths bundle of care meeting and to reflect on what the program has achieved and particularly how those lessons extend beyond maternal and newborn health to the broader field of emergency care. SBBC has shown us something very powerful, that when structured training, practical tools, technological innovation, and system-level support are brought together, the results, as you've seen, are transformative. But what's so striking is not just the improvement in maternal and newborn survival, though those gains are remarkable, but also how those results were achieved. SBBC puts into practice the things we know that are essential for saving lives: the rapid recognition of a problem, immediate life-saving interventions, effective teamwork, and iterative learning through practice, feedback, and quality improvement. And many of you all who did the site visits yesterday saw this in person. But these are the same principles that underpin effective care for all time critical emergencies. So whether we're talking about a woman in hemorrhagic shock, a newborn in respiratory distress, a child with severe sepsis, or a trauma victim after a road crash, the core challenge is the same: the need for timely, coordinated, skilled action when minutes matter. So this is why the SBBC experience resonates so strongly with the WHO Basic Emergency Care Program. We call it BEC, or my colleagues in Africa call it BEC. And BEC provides a systematic approach, so built on ABCDE for first contact workers to rapidly identify and manage acute illness and injury. And what SBBC demonstrates is that these principles work in practice with repeated skill reinforcement, simulation, and outcome improvement. So these lessons are very transferable and are really informing the way we're thinking about how we scale the basic emergency care course and other key programs more globally. So while program-specific successes are important, they are not enough. We have to think about the entire acute care system. Maternal and newborn emergencies, like trauma or sepsis, don't exist in isolation. So they occur within this broader health system, of course, that delivers acute care. And this is really the vision that was captured by the World Health Assembly Resolution 76.2 that talks about integrated emergency critical and operative care. And that resolution was co-sponsored by over 80 member states, which is really remarkable. The world came together to get a WHO mandate on this. It affirms that these emergency critical and operative care services are not optional extras, right? They are essential components of universal health coverage and a foundation for health security. And we now have a global movement to realize this vision through the Acute Care Action Network that's been supported by the Laerdal Foundation and the American Heart Association. So, why is this integration so critical? You all know this, right? Fragmentation creates vulnerability. And if the facility can manage postpartum hemorrhage, but not a woman with septic shock, or it can resuscitate a newborn, but not stabilize pediatric road injury victim, then our systems remain fragile. Equally important by aligning and integrating the training and quality improvement programs across emergency critical and operative care to create shared language, consistent protocols, and team habits that we know translate seamlessly into one type of emergency to another. And we ensure that the patients benefit from the same high standard of care. So that truly resilient health systems must provide timely, high-quality acute care for any patient at any time across the full spectrum of emergency conditions and across the continuum of care. So from the community, right to the first level hospital to the referral hospital. So in closing, my reflection is this. SBBC is not only a landmark for maternal and newborn health, it is also proof of concept for how we can strengthen acute care more broadly. We need systems that save lives every day, that are ready for our next crisis, and ensure that no patient, whether mother, newborn, child, or adult, is left behind when an emergency strikes. Thank you all.
Excellent. That was a very short talk, but really, okay. Let me not exhaust the next questions. But I know we need the systems that provide timely, high quality acute care to all kinds of patients. That's my takeaway. Now, let's hear from Dr. King. You've been here for the past 2 days. What things do you see stand out compared to other global programs for emergency care? Looking at what the SBBC has done. And are you considering relevant, you are considering them relevant to training in other emergency care as a DEC program? I think I never looked at it that way, the way you say SBBC is not only about saving the lives of mothers and newborns. It is giving us the kind of insights on how the health system should be working. So can you put that, like, how can you align some of the things that you have seen to that direction of other training programs in emergency care?
Yes, of course. Good afternoon, colleagues. Good afternoon, friends. And I mean, just say it is a great pleasure and a privilege to be included and invited in this meeting. And Asante Sana for the question and for the opportunity to provide some regional perspective on how SBBC lessons will inform our path forward, particularly for emergency care initiatives in Africa, with a sharp focus on basic emergency care as a program. BC or BEC has now been active and delivered in 33 countries in Africa. The COVID-19 pandemic really amplified and highlighted the critical importance of this program in supporting time-sensitive care delivery, and it created real momentum that continues to drive emergency care initiatives and advocacy even as we speak. And it is a moment ready for us to use as a catalyst to scale up our efforts. From our African perspective, we've identified certainly in this very short space of time that we've spent together the last 48 hours, some key success factors that mirror what we hope to achieve within BEC and overlaps with SBBC. The first is the recognition of the important contribution of the whole team. Through BEC and now similarly as we have learned SBBC, we see the remarkable role that our nursing colleagues have to play in providing high quality patient and clinical care. It's powerful to see how nursing colleagues are included in our programs and as a result have a part in the wider program ownership, sustainability and advocacy. The second is the focus on the critical role of facility champions, and they serve as the anchor and the grounding within which to drive implementation at a facility level to engage the community and to serve the implementation from the ground up as opposed to the top down. What stands out for me as a learning point particularly is the insight to training approach that SBBC has adopted. And we have much to learn from the civilian methodology that SBBC has pioneered, and I look forward to future discussions in this regard as we continue to mature, adapt, and update the way in which we deliver effective basic emergency care courses and programs. In short, our regional experience shows that sustainable acute care improvement requires the broad foundation that BEC provides and the specialized excellence that SBBC continues to deliver. And so as we scale these initiatives across Africa with the overlap in success factors, I feel that there is a unique and a really valuable opportunity for us to consider our collective impact as multiplicative. And we are able to explore potential future collaborations within an integrated health system and a philosophy and vision moving forward.
Excellent. Thank you so much. I take away with me the key success factors from SBBC that you find them overlap with your principles at BEC. And again, that goes back to what the speaker said, that we are talking about the health system. So these success factors, if can be applied to SBBC, they can be applied to BEC. I think they can still then facilitate acute care, across all the patients. Now we're going to practical application. Okay, we are talking from this global thinking. We are getting out to the actual business on the ground, and we have with us Dr. Joseph Kalensi, the Vice President of AFM, and you are going to tell us, since you have started scaling up with BEC using the SBBC approach in Uganda, what are your main takeaways from this trip, and what are you most excited about?
Thank you very much, and it's a great pleasure to talk with you this afternoon. We're not coming to this trip. We're talking anyway. Our task was to observe, pick lessons, and see and identify areas of synergy. So yesterday, after a very long trip, we ended up at a site where we were observing in real time a simulation that was done by a team of nurses, mainly doctors, lab techs, who were performing a sim around this patient who was a mother that was having postpartum hemorrhage, and they simulated the way the medical team would come together and provide care, but also afterwards debrief. The whole time this was happening, I was remembering a case I had about 2 months ago in the Emergency Department while working in Uganda. Well, there was a mother, at this time she ended up in my emergency department because she had a fractured teeth field. And so the emergency department team had a certain approach that they were following. When they reached the part of the abdomen, I said, this is not easy. They just call Obs and Gan. So when Obs and Gan came, they had their approach, then the emergency team had their approach, but it's the same patient. So I was thinking, when I got that scenario in my head and I was watching, I said, this would have been a perfect scenario we could actually create and bring the teams together. So while we're debriefing, one of our colleagues mentioned, we noticed that she asked about who was the board members in the resuscitation that were having the session. I said, first of all, thank them for an excellent simulation, but asked other members of the other parts of the hospital involved in this, because I think this would be a great opportunity for them to work together. I said, yeah, and so we were thinking at the back of our heads, if this was something that was used broader and also touched on different other parts of emergency care, it's such a powerful thing. If you saw what I saw yesterday, I can remember everything that happened. And I said, this is something that you can actually use in basic emergency care. What was exciting was that it was in situ. That's another word I learned, in situ. You know what in situ means? In situ means it's in the actual clinical space. They're using exactly the resources they have in the clinical area. The exact same people are doing it, but also there's also an area where they can go and practice the skills they would have seen from there. So the learnings I got was the power in simulation. Number two, the power in people being supported to support reflection around what to do. And number three, which I want to put is how do we, because the question was really answered yesterday. This was for babies and mothers. But we have a much broader spectrum of emergency care that also exists as a training. So how do the two worlds come? The methodology is excellent here, but we think it can be spread across more so that the next time we have a sim, okay, really good sim that has that same patient that has a baby, but also has a fracture, so that we somehow find a way in which we can address more of those types of scenarios going forward. Thank you.
What a powerful way of summing that up. Because, sometimes we think of disciplines, but then the patient walks into the facility, they have their comprehensive needs as a human being. And Dr. Joseph is reminding us of having multidisciplinary care. It's not like I'm an obstetrician, I will look at the pregnancy, and I don't care about the leg, which is failing. And I'm an orthopedics, I will fix the fracture, I don't know if the fetal rate is okay. So so I think, in fact, I want us to take that as our global thinking of how we are summing this up. Let us consider the people we serve and their needs, and not our specialized areas. And now that opens up the discussion. I want people to reflect, question, reflect, guide, or provide any insights. Now, you can ask any question from since you started in the field visits until now. And these panelists here will serve as experts. And if they can't help, they will choose someone to help from the audience. Okay, very good. I need people to help with the microphones. And now this is a global reflection. We have been here for the whole day of 2 days. We went to the field visits. We had chats. This is the time for us to reflect all this, what kept us here, and what our take away home messages from all this exercise. Yes, we have 2 hands there. Another one there. And we have a leg there. So we start with those 3. And then please, if your question is directed to any of the panelists, please mention, but if it's just for everyone, just also say.
Thank you very much. I'll just throw it into the air.
Okay.
Anybody who is ready for can catch it. Thank you very much. I think for me, one of the major take-home from the entire visit is the practicability, the usability, the cost effectiveness, and the sustainability of the simulation-based training. And for me, yes, it has started as SBBC, but I think it's a training modality that can actually be expanded to cover most of the service delivery areas within the health system. Especially for the fact that for this part of the world, we suffer to train our healthcare workers, and then the other parts of the world always poach on them and take them away. And we are left with huge gap in human resource availability to respond to the basic healthcare need of our people. So I think this simulation training, I don't know whether it's LADAL or GFF or any of the countries, but I think it's something that needs to be designed for the different critical service needs of our population, so that within each clinic or within each unit of service delivery in the health facility, this kind of training in situ, thank you very much to borrow your word, can be happening, whether it's for HIV treatment, whether it's for TB services, whether it's for maternal and child health services, whether it's any component of healthcare need that is required. And it's really going to address most of the capacity gaps in the service delivery. Thank you very much.
Excellent. Thank you, Dr. Balaji. Yes, thank you. Can we have another microphone? Go around. I think so that you have microphones. Please go ahead.
All right, thank you very much, Maseka from Zambia. I think my question is for especially the panel that was there in the morning, but also the colleagues who are already in the meeting. Please can help. I just want to talk about mMama. Very good strategy addressing the first delay in the community. I just want to lay issues to do with the limitation of the country where I'm coming from. When you talk of the first delay, mainly it's places or communities or rural health places where signal, we call it network in our country, is a challenge. And that is the main contributing factor when it comes to delay. By the time someone calls for help, they have to go and look for network, they really delay. So I want to find out how this has been addressed as they have implemented the mMama. Or does it mean it is only for areas where there is signal? Is mMama only applicable for areas where there is signal, or even when there is no signal? Is something that you've done. We would love to learn. Thank you.
Excellent, President. So we have here, and then we have a lady here. Can you give a microphone? Yes, and then next we go to Sandy. Please go ahead.
Thank you very much. I'm Dr. Sayyid Ahmed. I'm the National Coordinator for National Emergency Medical Services and Ambulance System in Nigeria. We started this program in 2022. At the moment, we have rolled out in 24 states of the Federation out of the 36. We have also rolled out some of the tertiary hospitals. Almost 35% of all tertiary hospitals are now doing emergency. We have basically two arms of the emergencies. We have the urban and the rural. And the rural initially will come rural ambulance services, but with the coming of their own new administration, we change it to what is called RESMAT as a last thing. RESMAT will be rural emergency services and maternal transport, focusing on maternal and neonatal mortalities. Why I stood up is to ask some few questions, having given this background. Now we have a new leadership of the WHO, question to the WHO, in terms of medical emergencies at the HQ level. And whenever there's a new leadership, you understand, I think it usually comes to a new agenda. We would like to know the new agenda of medical emergency in the developing countries, or in Africa, or in some countries in Africa that are actually pushing for medical emergency, especially in the ruralized part of the country,
where it is very important that we work together to save the lives of the poor and the vulnerable in the ruralized part of that country. Then the second question, what is the strategy we put in play in terms of training, especially with the African Federation of Medicine that have actually played a very great role for the last couple of years, training people in various countries. I think it is important to actually to note their own contribution, which is very tremendous and very much we really applaud them because it actually helped us a lot in Nigeria. And lastly is to tell us that we need to all come together with a common front as in Africa. Not to actually say this country is doing, this country is doing. We need to come with one concept where we adopt it. Like the issue of M-Mama is doing for the last 2 years. You understand? Where we are also doing something similar to M-Mama, because what we do in Nigeria is that when in the rural part of the country, not similar to the M-Mama, because when we went to Mananara, Ababati, we told that this is something similar to what is called RESMAT. If a pregnant woman actually visited a PHC, she will be registered. On the subsequent visit, she called around. It could be 112, that is the toll-free number, and what is called SaferBirths number. We have a number that is called under the RESMAT, called SaferBirths number. It's a 4-digit code. It also have 11-digit number in some of the countries because Nigeria is very big. In some part of the states where the 112 is not working, we make use of the 11-digit number or we make use of the SaferBirths number, whereby when you call that number, either of the two will happen. Either there's ambulance available will be dispatched, or a tricycle ambulance will be dispatched, or we'll make use of the any available NURTW, that's mean drivers. Drivers in the village. Some of the places that is hard to reach areas whereby no ambulance, no tricycle, but usually it's a village market, we only have one vehicle in that village. Such vehicles are registered with us and we actually dispatch that vehicle to go and pick the patient. And on daily basis, we have a kind of a meeting around 8 to 9 a.m. in the country to actually discuss how many births have you so far today, how many pregnant women were transported, how many deliveries have you actually received, what is the mortality, and what are the other complications. Thank you very much for the opportunity to give to this.
Thank you. So, time, do you have a microphone? Yes, please.
Thank you very much. My name is Dr. Pedro Adeyemi. I'm the newborn focal person in Federal Ministry of Health. My question is for Kenya. Do you have a referral? I believe you have a referral system. Do you have a protocol for newborn when it comes to referrals in these emergency ambulances? And also, how were you able to make the newborn component very visible when it comes to SIMO in your country? I would like answers to that. Thank you.
Okay, perfect. Dr. Sunday.
Thank you very much, Sunday again. Dr. President and Director of Programs and UI. Just a few reactions at the moment. Of course, we agree with everyone. This was a very wonderful forum to learn, but also exchange the network as well. I have a few issues that I think might be important to consider as takeaway. One is we have seen so many countries taking on board the SPDC model. Certainly, I think going forward, we should explore opportunities of having a community of practice that will keep on sharing the experiences, the lessons, so that they keep informing each other, and certainly having more and more forums like this to learn and share. And then on that, locally as local partners, I think also it's very important to keep the discussion going. A lot of programs are coming on the country. A lot of engagement. We have been thinking about how to explore more opportunities to learn across different programs. I think we should have more collaborative efforts to learn more from each other. And this program is one of the outstanding examples where it can always improve as a country. Now, another key point that I think could be a question for discussion here. When it comes to the simulation-based training, one of the very good innovations that is coming with is how you track in real time the training that happens across
We have seen here you can be able to track a number of simulations done by specific providers. Now, I have a question for discussion here. And when it comes to the technology that is needed, the platforms and everything, how much is it really available for other partners who like to take that on board? For example, Tamiwa is interested possibly to work and learn from the good work that SBC is doing. But certainly some of the difficult questions that it's coming on our minds, how easy is the technology available for third parties, I would say, who want to come in and so I think it's an area where we wish to learn more. And then another point which I think is for everyone to consider here, I'm a very strong supporter of facility-based training, but one question that always comes in, we have been used those types of training where you take providers to other settings, talk of other areas, and for them that's part of the incentives, that they have gone out the facilities, and certainly when it comes to vitamin M, it plays a part of that. So I think the big question here is how much are we balancing these cards here? That the providers are going to be trained on site, they are learning the skills, yes, and they are very motivated to learn. But some of those issues, how much, maybe those who have been working on the field, they can share some lessons and they possibly help us to understand more. But otherwise, that's the direction that I think we really need to see how best we can have improving skills within the facilities. I think for now I'll end up there and I'll come back later. Thank you.
Sure. Thank you. I think let me take the last answer. That's the very last comment. Meanwhile, I'm asking for panelists, if you think there's anything you have to respond, please. I know this is because it's a great show and it's Kenya, and you have some insights. So, and then when you are responding, you also give your final remark. Please.
Thank you very much, and thank you to all the panelists. I'm Dr. Mia Mukire, OBGYN by training, and I head the Family Health Department policy and facilitation of implementation of policy. My question goes to Tanzania. I was just wondering, in terms of standardizing practices, instead of standardizing the SINBIGI, the training package for SBBC, vis-a-vis looking at other training packages like BBC, WHO has spoken to, and various other training packages. Did Tanzania come up with a protocol or a manual, to guide this training across various facilities? And also, is there already an existing protocol on the QI component of it? That was something I found quite interesting. Diverting training from the name and shame culture to the quality improvement culture. So I'd like to know what Tanzania did, or you just allowed the facilitators to come train, and is there a standard protocol? Because we're looking at it from the angle of institutionalizing it, so that at least every one of us, and when there are new knowledge that's evidence-based that will give us better results, then countries can always, through policy, ensure that the right document is there to guide implementation all over the nation, standardize it, and have the results. Thank you.
Perfect. So I'll start right in responding. I'll start right from my left. I go in this direction. You pick the things that I want to use it to, and it's okay if you don't have any response, but you can say your own word.
Thank you so much. I'm going to respond to the comments that I was asked to about the pre-hospital care. From the WHO side, while we've done an enormous amount of work around the basic emergency care course, because we have seen in our impact studies that it reduces mortality by anywhere from 35 to 50% amongst district hospitals across Asia and Africa. We still keep an eye to the system that I was discussing, and so we are also building kind of guidance and normative guidance for both community first aid response, and very recently we've just released our pre-hospital toolkit, This has been very long in coming. We are very happy. We've just released it. And it includes a lot of different operational guidance that will really, I think, help countries that are struggling, because there's a lot of countries that really struggle with their pre-hospital care and often ask to make requests to WHO. So I'm very happy to share with you all that that is now in the public domain. And I wanted to also just reflect on your comment about ensuring that we're reaching the most vulnerable and those often who are living in rural areas who actually cannot activate the system, right? That are having a lot of issues with access. We've talked a lot about that in this forum. And I think it behooves us, and it's so important for us as people who are really informed to be advocating for this voice. There's a couple publications I can point you to. One is in the bulletin of the WHO, specifically about kind of a human rights-based approach to emergency care. But I really appreciate that you raised that. And I'm happy to talk with you after about some of the specific resources and hear what you have learned is relevant and true. I'd love to just pass on those specifically about your question to APEM.
Yes, thank you so much for your comments, thank you for your question. From the APEM perspective, our mandate, we take our mandate and our marching orders essentially from our network of members. And so it is wonderful for us to see and observe and be mindful of the incredible work that is being pursued and achieved within Nigeria. And certainly from the AFM perspective, on behalf of the organization, we congratulate you on the incredible efforts and progress that is being made that certainly does not go unnoticed. In terms of your question as to how best AFM can respond, we take a three-pronged approach, essentially. One is that AFM will develop insofar as we are responsive to the feedback and the ask from our member networks for in-house resources. And so we have developed a handbook for emergency care. We run an emergency medicine journal, which is indexed and open access. And we host and run biannual scientific conference. And that supports and creates an opportunity for really powerful collective discourse for regional communities of practice, whether that is Africa as a regional collective or whether it is specific to the West African community. And so we have both responsibilities that we take very seriously to represent the interests of Africa as a whole and the particular interests of North, South, West, East, and Central Africa. We are deeply rooted in being able to provide and be responsive to contextually appropriate needs and requests. And so, insofar as we are more granular in our support, we try as best as possible to align to national strategic frameworks, to national priorities, to sub-national priorities, to community-based priorities. Because the last thing that we want is to create a parallel stream of efforts and siloed activities. And so as best as we can, we try and identify the stakeholders, or we are very receptive and we welcome any inquiries from those stakeholders that represent the interests of the nation, rather than for us to come through with a prescriptive framework or scaffold within which a country needs to adapt. We just don't feel that that is a socially or responsible or efficient way. So one of the mechanisms has been through our partnership and our collaboration and our implementation alignment with WHO tools, those being the pre-hospital care toolkit, those being the emergency care toolkit, one of which is included is a needs assessment and a complementary strategic framework and roadmap for operationalization. As far as possible, we try and enter in that way, so as best to represent, to reflect, and also to support the priorities that have already been identified, as opposed to us prescribing. I hope that is helpful, but once again, very, very happy. You always have time to unpack this, as much time as you would allow me, but I'm going to pass on. Thank you.
Thank you so much. So next, we have 90 seconds.
So
my 90 seconds. My reflection was around, especially from the site visit, was around the direct use of hospital needs to influence training. So the hospital teams identify certain needs. Let's say there was a case of PPH yesterday, then a system is designed around that, learning points are gotten, and then training is part of that. I think that's a very powerful way to link training to quality improvement. And for me, that was a good takeaway, how to use the hospital scenario, the hospital environment to be addressed by training directly, and then getting very clear indicators that can then be measured following that intervention. In BC, we have very, very many skills that we teach. I think the last, about 38 skills that are taught. If you teach it in a short time, maybe someone might pick 5 or 10, but if there's a way in which there be that are related to direct clinical scenarios, which then results in training, but more importantly, that there's a QI measure of what has been done, resulting in the scenario, I think that's very powerful, and I'll take it home as something that I think will influence training in the clinical space. So thank you.
Perfect. You are the specific question as well.
Yes, I'd like to respond to Dr. Tedro, the fellow newborn health over the 2 questions on the referral system when it comes to newborns. Currently in the country, we are having quite a couple of challenges when it comes to that. As you know, in Kenya, health is evolved. We have one national government of 7 county governments. So there are some counties that are doing better than the others, with having ambulances well equipped, even with incubator, biosipaks, and the referral is quite smooth, while others are not yet that far. So I think challenges, as we shared yesterday, our challenges are almost similar, but we are working towards it. Tanzania is a step ahead, and it's good that we are here to also learn from them on how to get better. On your next question on how are we able to strengthen the end in Simo, and I'll give you a scenario. Just last year, as part of our MOC training, the N during training, which is a 5-day full-day training, was only given 2 hours. It only got to Kenya Pediatric Association, we at leadership to advocate on prioritization of the newborn. So the N right now as we speak is a full day, but remember that the country also have comprehensive newborn care. So I'd say it's majorly advocacy from our Pediatric Association, advocacy for us, pediatricians in leadership and our leadership as a whole, and the support of leadership being invested in maternal and newborn health. Currently, our minister and our permanent secretary always say if the mother and the baby die, there's no role for us in government being in office. Also, when the other thing that has made newborn visible in our country is the global initiative, every woman, every newborn, everywhere, aiming to reduce our newborn and maternal mortalities by 2030 as per the SDG targets. And the current rule that we give those in the counties is the mother-baby diet should never be separated. If an intervention is given to the mother, think about what is the baby getting also in return. So my final remark is, you see the same urgency you have when a mother dies in a facility, everything stops. Until we have the same urgency when a newborn dies, the numbers will never fall. So also on the same of not leaving the newborn behind, we should ensure that we are all advocates, not only for the mother. I know most of the conversations always speak to the mother leaving the newborn. So we are all advocates when it comes to advocating for the newborn, not only to survive life, but to transform their lives.
Thank you very much. As well.
So I'm going to respond to the question raised by everybody around when you need to intervene and what's not there, which actually informed the need to always triage every pregnant woman, identify women at risk, and then be able to do what is called the complication radius and the proper birth plan. If you know a woman is at risk, you will be able to do emergency evacuation, you will link to the right facility and ensure that you don't run out of network, that there is any delay. That's actually a second delay, not the first delay. So to address that. Then secondly, I know what the emergency general also said, around the need to actually have the proper integration, which I mentioned, the coordination of all the multidisciplines in terms of SBBC. And even beyond that, I remember as Commissioner, in my state, I set up the emergency medical services. And in fact, when an emergency or accident happens, what happens is that the first person to be called, of course they call the communication system, and then it's called the dispatch. First, to the security, we have a joint task force who will get there to ensure that the place is safe. And then second, the task force will call, there's an inferno, they call the firefighters. And then the paramedics will now come in with the ambulance with the excavating equipment. And then the rescue will happen within the period of 12 minutes, just to say that. But so, in terms of last comment, I'm super happy. I think SBBC actually sits very well with the Army, and then we're going to integrate it. It is clear to us, like I said, in the invitation of the President, we need to stop the needless maternal death. We need to ensure there is no risk in bringing another life, and every baby must live to see the 50th birthday. And what is more important is that the solution is just right here. We want to save life of the newborn as well as the mother. That is neonatally, and then the new bat, mama bat, and the mama maternal. Thank you.
Excellent.
Yeah. So I think for me, my key takeaway, I guess a few takeaways. One is I just flashed back to about 2 years ago when we had that meeting with Tori, Jennifer, and a couple of people from LGH. And to be here today is such a privilege to see how much SBBC has diffused beyond Tanzania to other countries. So for me, the learnings are that, one, we need to focus on the results and the outcomes. I think for too long, a lot of our programs in Africa, we care more about processes and, lots of talk, and maybe less about the actual outcomes. I've really learned that one of the things that has made SBBC last as long is because perhaps the foundation was that we just really needed to save lives, and we treated this as an emergency that it really is. And so for me, the takeaway is, to go back to Nigeria and continue to impress on the government and my colleagues that let's really focus on the emergency. It's not acceptable moms and babies die. They're more than numbers. These are people, these are potential, and perfection for us is the enemy of the good. So let's get started, no matter where we are. Again, like I said, when Chai adopted SBBC, which by the way was not funded, it was really because we wanted to improve outcomes. It wasn't because we thought it was a shiny new object. We saw the potential, we thought it was going to make a difference, and obviously we're here now and we can see the difference that it makes. And so for me, it's to say, this just reinforces the importance of why we have to focus on outcomes and do what is needed to save every single life. And eventually the money will come, the attention will follow, but at this point in time, let's just really prioritize mothers and newborns and do what we know works. Thank you.
Yeah, for me, it's not just to answer, but let me just share experience on the question around vitamin M, right? Yeah, so I'm not sure how sustainable this is, but for SBBC Borno, right, we have introduced some regular platforms where we have the mentors and champions, as well as data collectors, come together, at least on a monthly basis, to share experience and understand themselves, which we usually organize it away from the facility, even if it's not that big, with regards to vitamin M, but at least it's refresh them and motivate them in so many different ways. And what I have learned, right, from this interaction we have so far with the frontline workers, it doesn't take too much to motivate them if we really plan to, or if you have an intention to do so. For instance, from our experience so far, every week, Monday or Friday, we'll have a discussion based on the data that we collected using the platforms. For instance, we go to the facilities and discuss on the number of times the health professionals have practiced on neonatal life or neonatally, right? They'll get very motivated, knowing that their efforts have been recognized, and then there is a kind of system that is collecting the efforts that they are making in the facility. And this is something that their supervisors at different levels are also able to see. This by itself motivates them a lot. So this is what actually I want to share, versus not big when it comes to vitamin, but at least it keeps the champions, the providers, or service providers motivated. Thank you.
Yes, I don't think we could have a better last person to speak. So please.
Thank you, my colleagues. On the side of GFF, actually GFF has seen the need and interest for countries. And GFF also provides guidance, operational guidance on how well to maybe to take in SBCC in country in terms of resources, what resources are required to begin the process of implementing SBCC in countries. So the countries also can reach to GFF for that support. Lastly, I can say take home from me now what I observed. These healthcare providers in these facilities, they are well motivated seeing the results. It makes them continue. So maybe countries should learn on how best to have a functional, effective champions who will keep on training and retraining the team in those facilities. It will make a big, big difference. Thank you.
Yes, that's coming. There is a question for training packages and all that.
Yeah.
The minister is here, the council of the ministry is here, and that will not be answered from this side. The next session, which is like 5 minutes, was for the government of Tanzania telling us how they are scaling this up and how they are taking this SBDC, and they will answer that question during that. So it is taken note. But now I would like us to close this plenary. I just want to ask your favor to really put our hands together for this wonderful group. This was a very enriching discussion. In fact, we didn't only learn about the SBDC, we learned about the DEC, we learned about Kenya, we learned about Nigeria. So it was like they're all discussion here. Now, ladies and gentlemen, as we are heading towards the end of the sessions, we have only one session remaining, and I would like to invite Dr. Felix Ibunga, who is the Assistant Director at the Ministry of Health, in charge of newborn, children and adolescents, because I know there are people who are interested in newborn. It does not just give 1 hour in the training, we give more for newborns. And Dr. Felix Ibunga will tell us what are the plans for the government of Tanzania with all the lessons we have seen under SBDC, for getting them rolled out within the MNH interventions or programs, and they answer the question you asked about the training partners. Karibu Dr. Ibunga.
Good afternoon to everyone here. Thank you so much, the moderator, Dr. Dunstan. I think before I talk about the plan and scale from the lesson from the SBCC, I will start by responding to the question. Coming off the SaferBirths band of care, for us, but for everybody, I think we all agree when we talk about the labor monitoring, when we talk about the legal succession, occupation management, is not a new concept. This is a concept which are already available and existing in our national guidelines. Except that the different approaches and some innovation to be used as research remain different. But since this was an intervention with associated with research to provide more evidence and for the decision making, but also by understanding that it is going into different regions and that we need to have uniformity. We allowed the teams to fit and develop some of standard operating procedures so that in whatever regions or facilities implementing, they will be using that protocol which we adapted from the existing document. So that is how we did. So we have those protocols that guided the implementation. About the learning and how the government is planning to scale up, I think one of the strengths of this project, the government and the partners of the high dome, there was a thin line of who is the student and who is the teacher in terms of the learning. We are learning together. And in fact, even before they started writing the first proposal, the first thing was to contact the Ministry of Health to see in terms of priority strategies and interventions. So we have been doing together in each and everything, learning together and see how we do things as we go forward. But in terms of how we proceed, as it has been said this morning, that capacity building stands or accounts for the high proportions. That we had also some evidences that was mentioned from Tamakwan in the morning, that even through review of the maternal mortality that had happened those years, 2022, we had again realized that 80% of it were associated with the competencies, even in the place where some equipment were available and human resources were there. So coming of the SaferBirths bundle and this achievement, which you just realized, it was much of learning of approaches, as I was saying, where you have the equipment, but not only the equipment, that before you start doing implementation, you will develop, you will have the guidance, as I say, you will have legal sensitization to increase the buy-in from the legal level. You will have the master trainers, the regional trainers, and then the facility champions. Something we saw, it was very much accepted in the regions, but these results we just see. But again, from what together with our colleagues. I think though you will remember and mentoring who are here. Initially, our plan was that we reduce 50% of neonatal death, 10% of maternal death, and 25% of sterile death. The results at the end, 75% maternal death reduction, 40% reduction for newborn death, 18% prenatal. I mean, that one was the learning for the government, that we knew that we are focusing much of labor monitoring, newborn gestation, and feeding management. Maybe the question was, and we believe the gestation was being conducted very well within the labor. But unfortunately, the gestated baby, I think nobody is gestating a newborn for 24 hours. Within 24 hours, the baby needs to go somewhere for extended care. So if you had no neonatal unit which is working, you had no CPAP that is working, maybe that's why you did not see the reduction for the newborn care was not that much as we observed for the maternal care. But again, using the sterile death, you need an intervention that is starting in the antenatal care. So from this learning, we said we are going to make the national rollout for the SBCC, but this time not the SBCC alone. We are going to add other interventions that will synergize and improve more lives. And that's what you hear people say SBCC plus. So the national rollout for the government, which are going to start soon, using the DFF funding, but again using the beginning fund, we are going to roll out something known as the SBCC plus. And SBCC plus basically is adding some intervention starting from antenatal care. When we are talking about antenatal care, we make sure that the equipment needed, the human resource, that the capacity building for the key competencies starting the antenatal care. We go to the labor with the equipment for the safe birth ban, but also other equipment necessary for other common competencies. And after the labor, we have to go within the NICU to make sure that there is some of the key and essential equipment that will help for respiratory disease management, feeding, issue of thermal care, units management, the whole of the level 2 care. And for this matter, we are going the same approach. We're going to make sure that we bring together the expertise from the HIDO, expertise from the NEST system, from the training institutions, and very soon, if not the end of this month, early next month, we are going to organize a stakeholders meeting where they sit together and plan to see how things, how the package can look like. The expertise for simulation training, I don't know. Sim begin, should we talk about the lift? Even the next will come with the expertise so that we have the national package that is integrated, that is taking, is looking across different parts. But again, we have realized, in most cases we trade and we find out that the providers in these facilities, they have some upgrades. Going in the nearby, the training institutions, the teachers, they have no knowledge about what is happening. And this time, we are planning that the same package which will be orienting the regional trainers for SBC Plus, the same will be used to orient the tutors in different training institutions before we go the further for like putting in curriculum. That is essentially what we are planning. And as I mentioned, the DFF, we're going to start heading into 2 regions. The 12 region will also follow using the beginning fund. And the future implementation will follow this the national package which we have evolved, as I mentioned. Thank you so much.
So as you heard from the ministry, we already have the SBBC Plus. That means they took everything under SBBC, they are adding some few components to it in the continuum of care, from antenatal to postnatal, both mothers and baby. And they call that SBBC Plus. And now they have funding from GFF to implement that, and they're also funding from the Beginnings Fund coming to implement that. So Tanzania is well covered, and we're already taking up the lessons from the SBBC. Another round of applause. Now, towards the end, we'll have a group photo at the end. Of course, we'll have multiple groups, so please don't leave, because we need all of us to be in the photo at some point. But now I would like to welcome Todd to come and give both of things. Yes. Just thank people who came from all parts of the world. Before we can have announcements from Robert, and then we'll have the executive director of the hospital, Ingrid Kusuma.
Well, thank you. I was asked 5 minutes ago to reflect a little, and I reflected all day. I had the privilege of coming to Ireland the first time in 2009 when the Helping Babies Breathe program was introduced. And the study started at 8 hospitals in Tanzania and led to the landmark paper that Georgina Musino was the first author of, that showed the potential of Helping Babies Breathe. And that triggered a tremendous interest in the program led by USAID. And over the years, 2 different global development alliances, first Helping Babies Breathe and then Survive and Thrive. In 2017, it was estimated that 1 million birth attempts have been trained in this program. But, yes, that's what But at the same time, research continued, and having epicenter here in Thailand about the impact of this training. And it was shown somewhat to the discouragement of some of us that it didn't automatically translate into more lives saved. So there was a need for a paradigm shift in education. And over the years, very much happening here at Thailand. By now, 40 PhD studies have been started, and well over half of them completed. Quite a few of them Tanzanian PhD fellows. And the program has been challenged and iterated and improved again and again. And we have been very privileged to be part of that process and trying to respond to some of the findings of the research. The Navajo Foundation Board visited, as you heard, the first time here in 2011, and we are very, very pleased to come back and see what has happened. This has been a kind of signature program, because what is motivating the Navajo Foundation Board is really impact potential. And seeing this develop over time, and very much, again, led by Haydn, and the people we met for the first time we visited, Pascal, Robert, Esto, and Ben, that are also taking you through the history and the current issues. I think that is very much also the reason for the success of the program. People with a passion, people that really continue to challenge what is the impact potential. And that has developed a culture of excellence that is spreading to the program. It wouldn't happen without it, I think. So there have been discussions on what are the criteria for a successful program, and that takes leadership, strong leadership. It takes research and evidence for quality training. It takes data-led QI programs. And these factors really trigger then a cultural excellence that is all decisive for taking the next steps. So it's a dream come through to see that the case of Tanzania has been proven to the extent we heard today, and that is triggering this interest from so many new countries, that it has become a very interesting program for the global financing facility, and that it's also now spreading to a WHO-led basic emergency care course. So it's been really fantastic, and the best proof of it all was probably the visit to some of the sites yesterday. And I heard from several of you that these visits were very, very impressive in all, I think, 6 different hospitals that were going on. So I just want to thank everybody who has contributed so much to this on behalf of the Dala Foundation, on behalf of Dala Global Health, that has been able to play a small role in this. And this day really stimulates us a lot to continue the collaboration. It will be wonderful to see this really live up to its potential, which has been presented today. Thank you very much.
So we'll get some announcements from Matt, and then we'll invite you there for final remarks.
Good evening, everybody. So at 6 p.m., after finishing at 6 p.m., we're going to have a cultural dance just outside this conference room where we had our lunch and tea. And this will be followed up by dinner at the same place. You're all welcome. And during that evening event, we will also have some announcement for the program tomorrow. But for those who are catching their flights tomorrow at Kia or Arusha, please contact Beatrice so that she can organize transportation for you. Thank you very much.
Good evening, everyone. Habari za jioni. Sorry for a very long day, but we thank God now we have come to an end. A very long day, and it was a very fruitful day. I hope we have had a very good discussion and very good insight of what is happening in Tanzania and what we can take back home. And to finalize our day, I would like to call upon the chaplain to give us a closing prayer. And after closing prayer, the moderator will take charge on how we can sit here and take a photo. Karibu sana, chaplain. Okay, good evening, everyone. Yeah, let us now pray. Close our thinking. Let us pray. Heavenly Father, I thank you for this wonderful day, the meeting that has been done here. I thank you for all the participants and all discussion held here. Thank you so much, our Lord, and I pray that as we are departing, be with each one of the participants of this meeting, guide them and lead them to and bring them back safely. I pray all this in your name. Amen. Amen. Asanteni sana, niwatakie baraka za Mungu. Mungu awabariki sana. Hongereni kwa mkutano.
Asante sana. So we will quickly take some group photos. I ask that we have So may I ask the following group, the following people to come on stage, just to be part of the all groups. This will be representing us in all groups.